Insights from the world's best medical minds. You are watching TheRightDoctors.com.
Nucleic acid protein based. Most of the vaccines then would be protein subunit vaccines or viral vector related vaccines. But also an asterisk, which we should not forget, that there are efforts that, and this is the fifth category, there are efforts that are being directed at looking at existing vaccines to see whether or not they could elicit a more general immune response that would be beneficial, as opposed to the specific adaptive immune response that one gets when one gives a specific vaccine. So this is an area that's also being worked on. But what sort of lessons can we learn from the past to help us to ensure that we have a safe product when it becomes available? In this context, as pediatricians, we recall, some of us do, of the formalin inactivated RSV vaccine in the 1960s that was given, and this was associated with really bad outcomes. So what happened then was that in the 1960s, children who were seronegative for RSV, this is a respiratory syncytial virus, were vaccinated, and they experienced a significant increase in the frequency and severity of lower respiratory tract infection due to RSV after they got the vaccine and encountered natural RSV the season after. In other words, the virus that they were being protected against when they're vaccinated against that, when they encountered the virus, things got worse. They had enhanced disease, and actually some infants died. And this actually led to the observation that what was happening was enhanced RSV disease in a setting where there was a non-protective antibody response and CD4 T helper cell priming that was occurring in the absence of proper cytotoxic T lymphocyte activity to knock out the virus, so to speak. So this was a challenge, and what it led essentially to was the shutdown of the RSV vaccine development process, and it's been close to 50 years since, and we still don't have an RSV vaccine. So with that in mind, with SARS-1 and MERS, people wanted to look at this really carefully to make sure that there was not a similar concern. And in the mouse model of our SARS-1, enhanced disease was observed where vaccines did produce antibodies against the SARS-1 virus. However, when the mice that were protected were challenged, they found with infection with the virus, they had a immunopathology that was similar to what had been observed when one has enhanced disease. And in the mouse model of MERS coronavirus, the same sort of phenomenon was seen as well. So the bottom line is that companies and researchers are being extremely careful to ensure that moving forward, the full spectrum of safety related to these vaccines are evaluated. And this is just absolutely crucial. The second point in my framework then relates to access, where it's going to be absolutely important to ensure that we have proper access to these vaccines, and the community does have access to these vaccines if and when they do become available. So for example, will vaccines be given at hospital clinics, schools, doctors' offices, mobile clinics, pharmacies, prisons, correctional institutions? All of those need to be worked out, and now is the time to work them out rather than when the vaccine or vaccines become available and then one is scrambling to try to figure things out. Fairness, so this is really important, where we have to come up with some sort of a fairness principle, and I need to think about it now before the vaccines become available. Should priority be given to highest risk groups, for example? We made reference to the African, Canadian, African American, African UK population. Should they get priority? Should priority be given to people with medical comorbidities? What about first responders, the working force? Who should get priority, or should there be any prioritization? And that's something that we need to think about very carefully. Certainly with the advent of H1N1 and the pandemic in Canada, there was some prioritization framework that was in place. We also need clearly an effective vaccine, a vaccine that has been demonstrated to be efficacious, and when deployed, it works. And there's lots of research being done looking at antibodies. I'll show you a few slides. This is the normal immune response in individuals with COVID. Antibodies rise at about day 7 to 15. Certainly not much within the first week, but certainly after the first week, antibodies start to climb. But the point, without getting into too much detail, is that the different colors represent different patients, and people respond differently to the rise in antibody titers. Similarly, when one looks at the types of antibody responses in terms of how high the presence of neutralizing antibody titers are, there are some individuals in this particular study, some individuals who are below a certain level that, at least in this research study, was defined as not significant, meaning that they were not making antibodies, neutralizing antibodies, enough to protect them, even though they got COVID. And so the bottom line is that we need to think about this as we evaluate the vaccines to see whether or not people are indeed going to be vaccinated yet not protected. And this particular slide, which I've expanded on another slide to show you, looks at viral kinetics in patients with COVID. It looks at on the x-axis the days from symptom onset, and then looks at individuals with a strong antibody response, weak antibody response, and no antibody response. And the point I want to bring out is that some individuals, at least in this particular cohort, a significant proportion of individuals did not have an antibody response that was measurable, and others had a weak response. So these are things that are informing vaccine development as we move forward. And finally, with respect to effectiveness, recent data show that patients who were studied during the acute phase versus the convalescent phase, individuals in the acute phase who were asymptomatic had less of an antibody response compared with their symptomatic counterpart. Viewed on another slide here, in the top would be the acute phase, and at the bottom would be the convalescent phase. And the bottom line is that symptomatic patients were much more likely to have a significant antibody response compared with their asymptomatic counterpart. What does that mean? This probably means that we have to be very careful with respect to the so-called immunity passports, because it might well be that individuals who are asymptomatic might not have an adequate level of antibody response that is detectable using some of the various assays. So this is something that we need to look at very carefully moving forward. Other studies are being done and have been done to look at T-cell responses, because sometimes it might well be that individuals don't have much of an antibody response, but when you measure their T-cell responses, they do have adequate T-cell responses. Now, we also need to bear in mind that in this framework, vaccines have to be timely. We can't wait 3-4 years for vaccines. That's going to be a big deal. We'll be all, quote unquote, toasted by then. So we really do need a lot of effort, a lot of international coordination to make sure we have the timely arrival of vaccines. And then finally, a yearning. I couldn't find a better word than yearning, but we must want vaccines. And we need to do research, better understand why is it that some groups are not terribly excited about vaccines. And these are data, and this is really important for us to think about moving forward. These are data from the United States, the Pew Research Corporation, and they looked at what proportion of Americans would accept a vaccine if it became available. And it's a busy slide, but I just want to point out 2 areas to you. First, where the cursor is, 25% of white Americans said no, they wouldn't take the vaccine, but 44% of Black Americans said they wouldn't. So that's a big deal, recognizing that African Canadians, African Americans represent a high risk group. They're disproportionately affected. And if you go down further to connections with religion, you see that Black Protestant folks, 42% said they wouldn't take the vaccine at all. And a slightly higher white Protestant group, 37% compared with the overall population, suggested that they wouldn't take. So clearly, we need to do some education to ensure that we'll have adequate coverage. If not, we'll be challenged. These are data that relate to the varicella vaccine when it first came out in the United States in 1997. In the first year, in some of the surveillance regions, they had less than 30% uptake. In the second year, it got up to 98%, and then so on and so forth. The bottom line is that communities are often very skeptical, and so it's really important to work on messaging to make sure that everyone is speaking and delivering the same message with respect to vaccine. And with that, I'll make one comment, and that is one of the challenges moving forward is going to be to try to correct the gap between the messaging coming from the scientific leadership versus the political leadership. And so we've seen in this part of the hemisphere, in some major countries that will remain unnamed, that there's a gap between that scientific leadership and the political leadership, mixed messages. Hopefully we'll get it right for vaccines. This is absolutely crucial. And with that, I will thank you very much indeed for having me present to you today.
Wow, thank you very much, Professor Upton Allen. Just right on time. I was having a difficulty saying, how do you stop, a very learned person, experienced person, passionate person from continuing his speech, even though we are mindful of time. So I must really thank you for sharing with us your experience. You've been able to draw attention to some of the issues in the pathophysiology of the disease and why some infections are possibly mild and some are possibly severe. I guess we're going to have plenty of time to ask questions, but I think I should just also mention that you drew attention to the need to flatten the curve so as to protect the health system or to enable the health system to be in a better position to respond. And then, of course, in Canada, you are still a long way to herd immunity with only about 10% of the population having the antibodies. Of course, the majority of cases are in Ontario and Quebec. That might enable you to target resources at those areas. I guess that is the point in epidemiology that you are drawing attention to. And then, of course, the population group that is affected it appears not to be a pediatric problem. It's more in those who are 30 to 50 years old. And then, of course, the hospitalization rate at about 17% can also enable you to plan the use of resources. So I must thank you. I'm not going to take away from the contributions of the many people who are on this platform. They are going to ask questions, but we will just thank you and thank you again for your time and the contributions that you've made on this platform. So if you permit me, I'll go on to the next speaker, and then at the end of it, we will then throw the floor open for contributions from participants and questions. I hope that you'll be able to stay with us through all this so that you'll be able to share further your experience. Thank you very much. So it is then my pleasure to invite the next speaker. Thank you, Professor Allen. So it's now my pleasure to invite the next speaker in the person of Dr. Abimbola Bowale, who is going to share with us his experience and perspectives on clinical case management of COVID-19 and the current rarities and best practices in Lagos. Dr. Abimbola Bowale is the medical director of the Mainland Hospital Lagos and the head of the case management pillar of the Lagos State response team. So he's been at the battlefront since the first case came into Lagos and Nigeria on February 27th of this year. So it'll be interesting to listen to him, to learn from him what has been his own experience in Lagos. Dr. Bowale, please, you have the floor. Dr. Bowale, are you with us?
Yes, I'm with you. Yes, I'm with you. I'm with you. Good afternoon, Professor Oshibogu, and good afternoon to everybody. My name is Dr. Abimbola Bowale, and I hope my slide is seen by everybody. I work at Mainland Hospital Yaba, which is the foremost infectious disease hospital in Nigeria. The hospital was established a long time ago, in the 30s, as a sanatorium for people with infectious diseases. And over the years, we've handled various forms of infectious diseases, including in 2014, Ebola, 8,000 plus deaths and 160,000 recoveries. Now, these are the regional distribution of the disease. The Southern African region had the highest number of confirmed infection.
people on the, when time is up. But truly, we're trying to be within time. We must thank you for sharing your experience with us. You've told us how countries can learn from previous experience, and how in Lagos, you learned from the Ebola experience to build some capacity, and now that capacity has now been able to at least assist you in responding to the COVID-19 outbreak. Of course, we also drew our attention to the geographic distribution of cases in Africa, with South African region accounting for the largest number, and the Central African region accounting for the lowest numbers. You drew attention to challenges with diagnosis. Of course, we're not testing as much as we should do. And you also drew attention to the limitations with rapid diagnostic testing, which in fact is not currently approved for use in Nigeria, because there has not been any that has been found to be valid or to be sufficiently valid. You also drew our attention to the various policy and policy shifts from admitting all positive cases and now to admitting only severe cases, and then managing the mildly and the asymptomatic at home. And then, of course, you also drew attention to the pillar of your case management being largely symptomatic, and the use of alluvia, even though you do not have any written paper publication in support of the use of alluvia. So, of course, more males are affected, and the severity is also more in men. Maybe we should look for how can we protect these men. I'm sure that the Right Honorable is going to support us to find mechanisms to protect the men from suffering more from COVID and having more fatality and more severity from this. I thank you for your time and your contribution, but time is not on our side, but I hope that you still remain so that you'll be able to respond to questions that may come later. So we move quickly now from Africa to the Caribbean to discuss the regional perspectives on clinical case management of COVID-19, current realities, best practices, and challenges. And there's no better person to handle this than Professor Celia Christie, a professor of pediatrics and infectious diseases and consultant pediatrician at the University of the West Indies, and also, of course, of the University Hospital of the West Indies in Jamaica since some maybe 20, 30 years ago now. You know, she, of course, she's had a very distinguished career, which includes description of epidemic pertussis in highly immunized children in Cincinnati, which she published in the New England Journal of Medicine. I think she has had a very checkered history of practice and publications. And of course, she assisted in leading Jamaica's reduction of mother-to-child HIV transmission from 30% to less than 2% in 2015. And then, of course, the increased longevity of children with HIV/AIDS who are now aging up and starting their own families. Of course, this was published in the Annals of Public Health and Research in 2017. She's received numerous international, regional, and local awards for her research, over 240 manuscripts and abstracts. In Jamaica, she was conferred with the Order of Distinction Commander Class by the Governor General on National Heroes Day. It is indeed my pleasure to welcome Celia Christie to now address us. You are most welcome, Professor.
Good morning, good afternoon, good evening, and good day to everyone. It is indeed my pleasure, my privilege, and my honor to be presenting on the clinical case management of COVID-19 in Jamaica, in the Caribbean. Thanks to the organizers for this invitation. I hereby acknowledge the Right Honorable Patricia Scotland, other distinguished colleagues and guests. Indeed, I acknowledge everyone. Thank you. Celine.
Your slide is on, Prof.
Oh, yes. The Caribbean's population is about 44 million, and these persons live in 700 islands representing about 44 countries or territories. It is bordered by land masses of North, Central, and South America, and the waters of the Caribbean Sea, the Gulf of Mexico, and the Atlantic Ocean. The Caribbean is very diverse in its ethnicity, its culture, its language, and its socioeconomic status. The outline of my talk is shown. This summarizes the COVID-19 pandemic in selected Caribbean countries. You will see the population is 11 million each for Cuba, Dominican Republic, and Haiti. The Caribbean relies on tourism to sustain our delicate economies. The first cases of COVID were reported between March 1 and March 22. Since then, we've had a little over 53,000 cases and a little over 1,200 deaths reported in 33 Caribbean countries as of day before yesterday. The Dominican Republic and Haiti are now designated hotspots by the WHO, and recently we have had an uptick of cases in Suriname. And so the Caribbean is challenged by hurricanes, earthquakes, arbovirus epidemics, and the concerns of our small island states. Leadership of the COVID-19 response is from multiple collaborating organizations. Curtailing the first wave of the Caribbean epidemic was approached through multiple interventions. These included quarantine, isolation, and contact tracing of cases, closure of seaports and airports for border control, closure to tourists, suspension of schools and social gatherings, stay-at-home orders, and curfews. Businesses continued their activities through teleworking, and all hospitals were encouraged to strengthen their COVID-19 specific management strategies. Public health interventions included mask wearing, social distancing, and hygienic measures. The Caribbean is at risk for COVID-19, with some 18 to 35% of our population having one or more comorbidities. These vulnerabilities include age greater than 60 years in up to 24%, diabetes approaches 9 to 19%, hypertension 20 to 39%. Daily smoking in men occurs in 10 to 33%, obesity approaches 19 to 32%, and then we have sickle cell disease, cancers, and we have a few HIV infections as well. The standard case definition is used here as shown. We, however, believe we should include sudden anosmia and ageusia to improve the sensitivity of this case definition. Surveillance in the Caribbean is done through monitoring respiratory illnesses, and these will include influenza-like illnesses, severe acute respiratory infection, and admitted pneumonia. Surveillance is also done in communities among healthcare workers and in special settings, including airports, seaports, general hospitals, infirmaries, and correctional facilities. Nasopharyngeal sampling is performed in the Caribbean in a wide variety of settings. All countries now have PCR diagnostic laboratories or ready access to perform SARS-CoV-2 PCR testing. In Jamaica, of near 24,000 tests performed, some 696 SARS-CoV-2 positive cases have been so far identified. 26% of these were imported, 34% were from workplace clusters of mainly young people, 33% were contacts of confirmed cases, and 6% had no epidemiological link. Cases were skewed towards females in 57% and youth with a median of 29 years. So far, about 80% have recovered and 1.4% have died. None of the current cases in Jamaica are currently severely or critically ill. Now, cough, fever, headache, shortness of breath, and sore throat were the top 5 symptoms observed in Jamaica as in the United States. Anosmia and ageusia were prevalent, as were gastrointestinal symptoms, which sometimes we noticed occurred alone. Other symptoms are noted here. And so, COVID-19, we now know, is a procoagulant illness. It's characterized by thromboembolism and pneumonia, which initially seemed to mimic the high altitude mountain sickness. Severely affected patients may develop the cytokine storm with acute respiratory distress syndrome, disseminated intravascular coagulation, multi-organ failure, sepsis, shock, myocarditis, pulmonary embolism, and unfortunately death, which may be sudden. Investigations to identify this coagulopathy include a low platelet count or thrombocytopenia and high D dimers. Others include elevated fibrinogen, prothrombin, thrombin, and fibrin degradation products, which should all be monitored. The cytokine storm is shown by immune and other markers and include high ferritin, high CRPs, troponins, procalcitonin, interleukins 2, 6, 7, 8, 10, TNF-alpha, interferons, and GM-CSF. Others include lymphopenia, neutropenia, and eosinophilia. Electrolytes, kidney, and liver health should be monitored. There may be hyperglycemia and elevation of the CPK and LDH. Arterial blood gases should be monitored. Blood cultures may identify septicemia. Serology and viral samples should be evaluated for viral co-infections. Chest CT scans are performed looking for characteristic COVID features, ultrasounds to identify thromboembolism, and electrocardiograms and continuous cardiac monitoring to evaluate cardiac health. So, for antivirals, hydroxychloroquine and azithromycin were discontinued throughout the Caribbean, beginning sometime about April 2020. But now that remdesivir is standard of care, some countries are now trying to include it in their drug regimes. Dexamethasone, which is also recently included and recommended for standard of care, is also being incorporated into the treatment plan for severe COVID. The immune modulators, tocilizumab, is available in some countries. Intravenous gamma-globulin and high-dose aspirin is available for the pediatric multisystemic inflammatory syndrome. Anticoagulation is being used as low-dose enoxaparin for prophylaxis and high-dose for the critically ill with emboli, deep vein thrombosis, and high D dimers. Blood transfusions are used as indicated. Comorbidities and co-infections are managed on a case-by-case basis. These include the statins for hypercholesterolemia and ischemic heart disease, the ACE inhibitors and calcium channel blockers for hypertension and cardiac disease, antibiotics based on local antivirals throughout the region, and antivirals for influenza as appropriate. Alternate patient-directed anti-inflammatory and immune boosters include turmeric, ginger, fever grass, garlic, vitamin C, zinc, and fresh green juices, which family members bring to the hospitals to give their family members who are ill. The University of the West Indies is collaborating with the WHO to implement the Solidarity Trial throughout the region. So far, Jamaica, Guyana, and the Bahamas are all registered. Cuba is researching 19 medications to treat or prevent COVID-19. Jamaica is implementing 3 additional clinical trials. Convalescent plasma is now being offered. Caflanone, which is a flavonoid, and dolutegravir, tenofovir, and lamivudine in combination are also being made available. Other research is also ongoing, as noted on this slide. So how do we monitor our patients? Oxygen support is used to maintain a target oxygen saturation of about 92 to 96%. Low flow oxygen of up to 8 liters per minute is delivered through nasal cannulae or through the non-rebreather face mask. If the patient is not maintaining oxygen greater than 92%, or the respiratory rate is greater than 30 per minute, or the systolic blood pressure is lower than 90 millimeters of mercury, then a transfer is made to the ICU. There, high flow nasal oxygen at 20 to 60 liters per minute is given to provide a higher FiO2 with a preferred rate of less than 30 liters per minute. This delays intubation, prevents escalation to invasive ventilation, and delays the excessive work of breathing. This also reduces the mortality and the morbidity from ventilator-induced alveolar damage. It reduces intrapulmonary shunt and congestive cardiac failure. It improves the VQ mismatch and also mobilizes and drains secretions to thereby improve outcomes. If this fails, then we move to BiPAP, positive pressure ventilation, or invasive mechanical ventilation. We try to nurse our patients in their awake self-proning position for upwards of 12 hours a day, but not many patients can manage this. Physiotherapy is utilized. Resuscitation and volume assessment are performed while balancing adequate ventilation with overload, taking great care to prevent and to treat sepsis distributive shock. Dialysis is sometimes needed for acute kidney injury. Vasopressors, when needed, include noradrenaline as first line and vasopressin as second line. To prevent complications, closed suction is done in line to prevent aerosolization. Days of mechanical ventilation are shortened to reduce ventilator-associated pneumonias. Pressure sores, fever, catheter-associated infections, stress ulcers with gastrointestinal bleeding and coagulation are all tried to be prevented. Strict attention is paid to nutritional support, psychosocial counseling, family communication using electronic devices, as well as infection prevention and control from the time the patient presents to the hospital. About 4% of our patients are hospitalized. And here you see 27 of the patients that were hospitalized with COVID at the University Hospital of the West Indies, which is the regional hospital. All of these patients had comorbidities. The median age was 58 years. 12 of them were admitted to the ICU. There were 7 deaths, and 6 of these occurred in ICU patients. Now in Jamaica, we had 10 total deaths so far, and you'll see with the comorbidities here, cardiovascular disease, diabetes, age greater than 60 years, obesity, neurological conditions, renal disease, cancer, and hyperthyroidism were the comorbidities that we saw. Hospitalization is associated with adherence to infection prevention and control, WHO policy, as mentioned. Some hospitals have been repurposed with requisite administrative and engineering controls. Our healthcare workers are risk stratified and assigned with training and awareness and task appropriate personal protective equipment and hygiene, with the follow-up psychosocial support and testing. Post-discharge from hospital, quarantine or isolation, long-term complications of COVID-19 include depression, fatigue, pulmonary, neurologic, cardiovascular, and a host of other complications, as we know. Asymptomatic patients are discharged from quarantine and isolation after 14 days of a PCR positive test. Symptomatic clients end their isolation 3 days clear of no symptoms, with the earliest ending it 14 days after onset of illness. The critically ill or immune suppressed end isolation when it is decided by their care team after 3 days being asymptomatic and 2 negative PCRs 2 days apart. Follow-up is based on clinical course and the comorbidities. When healthcare workers are infected, they have the same discharge policy, except that 2 consecutive negative PCRs are required if they are caring for patients who are immunosuppressed or if they are caring for the critically ill. On day 7, if a sample remains persistently positive, then we say that discharge would occur at 21 days. On the 7th day, we do a wellness care check to ensure mask wearing, social distancing, and hygiene, and a mental health check. Contact tracing is done in the community. And here in Jamaica, for over 4,043 contacts that were identified, we had for 591 cases. The clusters and transmission chains are shown here. We had 133 chains of transmission identified, with multiple secondary, tertiary, and quaternary cases identified. And so we have identified challenges. The challenges, I guess the main one right now is the outbreak on the border of Haiti and the Dominican Republic. The Caribbean is still susceptible. In opening our international borders, we are expecting surges. There is significant healthcare worker anxiety and fear, bordering sometimes on panic. More testing needs to be done through the region using PCR, but then I think we need to move towards antigen and antibody test kits with improved sensitivity and specificity. The comorbidities in our Caribbean populations are high and they are significant. The clinical case definition for COVID needs to be improved to be more specific. The confidentiality of our Caribbean patients, their patient data needs to be maintained. Right now it's being spread all over because of the challenges that we're trying to overcome. Caribbean healthcare systems are still to be tested in the second round when we will likely be experiencing our hurricane season. Just to say that the Bahamas has still not yet recovered from Dorian, and Puerto Rico is still not recovered from the earthquake that they had there. There's also the issue that we're noticing recently of dengue and SARS-CoV possibly not necessarily co-infections, but the false positivity of antibody and antigen tests. And this really needs to be explored because dengue is now endemic in several regions in the Caribbean. Notwithstanding, we have enjoyed several best practices. The early closure of our international borders certainly halted community spread in the first round. The Solidarity Trial will allow controlled use of antiviral drugs and not depend on clinicians individually deciding on compassionate care, and thereby help us to accelerate evidence-based knowledge development in our developing countries. Cuba's medical brigade is a positive, and Cuba has assisted many other countries, including several in the Caribbean, as well as their vigorous research program for COVID-19 medicines. They have 19 so far in development. Hundreds of thousands of Cuban family doctors, nurses, medical students actively screen homes for COVID-19 every day in Cuba with rapid identification, contact tracing, and quarantine. Everyone in Cuba who is positive is hospitalized. Suspect cases are in state-run isolation centers for up to 14 days. There is mandatory use of masks, or persons are fined or jailed. The leadership of the Caribbean COVID-19 response has been excellent. SARS-CoV PCR laboratory diagnostics are available throughout the Caribbean. Contact tracing has been excellent by field staff, and this has shown that this has proven prevention of community spread in Cuba and in Jamaica. The University Hospital of the West Indies and the University Hospital and the University of the West Indies have put on several educational teleconferences, which began long before the pandemic was announced. And these have had local, regional, and international reach even now. This slide looks at the trends of cases and deaths as of just this weekend. And you'll see that it shows that the Caribbean countries are fairly doing well with regards to the proactive measures that they took to control COVID. Overall, our decisions were decisive, and we think they paid dividends, despite the fact that we still have to worry about what's happening in Dominican Republic, Haiti, and Suriname, and recognizing that we're in the middle of the hotspots in the United States and in other parts of Latin America, we have to pay attention. So finally, the Caribbean has done well, we think, in round one, but repercussions loom for our fragile tourism-dependent Caribbean economies. And so we are now embarking on phased, very cautious reopenings of our international borders to tourism with strict public health protocols and procedures. Jamaica requires a COVID-free PCR test result with geofencing of tourists on the coronavirus resilient corridor of popular tourist spots. We are using the Jam COVID app for tracking through wristbands and through cell phones. The Eastern Caribbean is doing the same thing, but they're using rapid test kits. At the airports, we're implementing screens, thermal scans, quarantine, masking, and social distancing. And this is all required from our visitors and our returning citizens. There is also gradual opening up of hotels, restaurants, beaches, churches, and businesses, and even schools as the children try to prepare for their 5th and 6th form examinations. And even as we do this, we all hope and pray for the best possible outcomes for the Caribbean as we work together to balance our lives and our livelihoods. Thank you for your attention, and thanks very much to all the persons who contributed to bringing us this far with the Caribbean response and assisting me in preparing this talk. Thank you very much.
Thank you very much, Professor Christie. That again was a very passionately presented paper. You know, we really appreciate your time and we appreciate your contribution to the health of the citizens of the Caribbean. Of course, you shared with us the case definition for the Caribbean, one of cough, fever, shortness of breath, sudden loss of taste or loss of smell. And then, of course, shared with us how many PCR tests have been done. Interestingly, there are more females than males. That contrasts with the experience from Nigeria. 57% of the COVID positive patients are females in the Caribbean. I think the reverse is the case in Nigeria. That's interesting. Of course, you shared with us the types of investigations that are conducted and the use of remdesivir and dexamethasone now are standard of care in the Caribbean. And of course, that you've discontinued hydroxychloroquine and chloroquine. Some other countries are just considering starting hydroxychloroquine and chloroquine. I guess we'll have to be waiting for more information as this pandemic progresses. You discussed the various clinical trials that are ongoing in the Caribbean, including the use of convalescent plasma. And of course, you have 4% of your patients hospitalized with an average age of 58. While again, up till now in Nigeria, most of the patients are hospitalized. There's now going to be a shift in policy towards home-based care. And then you draw attention to post-COVID complications, such as depression and then fatigue and pulmonary and neurological, as well as cardiovascular complications. And how in the Caribbean you've used contact tracing to more or less break or attempt to break the chain of transmission. You shared with us some of the best practices, early closure of international borders, very important strategy, and then your participation in solidarity trials. We sincerely appreciate your time and contributions. We hope that you will stay on so that we'll be able to answer some questions that may come on later on in this webinar.
Thank you very much. It was my pleasure and my privilege, and indeed my honor to be here today. Thank you.
Thank you, ma. Thank you, Prof. Yes.
Pleasure. Mm-hmm.
So it's now my pleasure to invite Dr. Menelas Nkeshima, the Vice President of the Rwandan Medical Association, himself a consultant physician in internal medicine and a member of the Rwanda Joint Task Force for COVID-19, to share with us his experience, in that region, as far as the case management and the current realities and practices and challenges are in his region. Dr. Nkeshima, you are welcome. You have the floor. Dr. Nkeshima.
Thank you very much for this invitation. I hope you can hear me very well. Can you confirm if you can hear me?
Yes, we can hear you, and your slide is on.
Okay, thank you very much. So, Your Excellency, Right Honorable Patricia Scotland, Secretary General of the Commonwealth of Nations, my brother, the President of the Commonwealth Association, Dr. Enabulele Osahon, I thank you very much for this opportunity given to us. All protocol observed. We are very privileged as Rwanda to share our experience on behalf of the region of East Africa for this global health threat of COVID-19. I can say that Rwanda as a country has always been a bit overprotective when it comes to address issues that would threaten the population health. And very early this year, as we heard the news that in Wuhan, you're having a new disease and it was crossing Asia, the preparation work had already commenced. And as you can see on this coordination structure, the management of a case requires support from multiple stakeholders. You can see that there is a role of having a commanding organ, because on a daily basis in the management of cases in treatment center. It does orient our teams in the rapid response team all over the country, watchers, communication, and isolation center. As I said, Rwanda has always been very overprotective for any health threat. And you can see on this diagram that we value very much the early detection, the early access to the diagnostic test. Here we talk about access to PCR test and early treatment. Either you come in Rwanda by air or by land, or you are detected internally based on the case definition, either using the symptoms, either using the links that we establish around the cases. All the suspects are evacuated to the isolation center. If they have symptoms, they are taken to quarantine site. If they don't have symptoms, So symptoms or no symptoms, you don't remain in the community. You are evacuated once you are labeled as a suspect. Once you have done your PCR test and it returns positive and you are confirmed case, you are taken to very well designed, selected treatment center. So this has to be understood. We don't have any suspect to remain to the community. We don't have any treatment, any COVID-19 patient who would remain to the community with or without symptoms, it doesn't matter. And after a case is detected, then it triggers the very robust contact tracing, and the contacts are also enabled to access the PCR test, and they are followed up on daily basis to see if they develop symptoms up to 14 days. And if they don't develop symptoms, the follow-up is discontinued. In Rwanda, about 80% of cases of COVID-19 experience an acute stress reaction, and this issue is addressed by the on-site psychologist, and sometimes on rare occasion it had required the visit by the psychiatrist. And of all the cases that we have had confirmed with COVID-19, only 40% are symptomatic, and a large amount of them will be having the mild symptoms of upper respiratory tract infection. We have had a few cases with GI upset, and this was well highlighted by the professor who preceded me in the talk, that we have these S receptors also in the GI system. And we leave the symptoms, Panadol, vitamin C, as we would do for any upper respiratory tract infection. If there is a concern that there is a superimposed bacterial infection, we have used antibiotics, and we commonly use augmentin. And if it's serious enough, the concern of pneumonia requiring oxygen, we might opt for IV antibiotics using the standard protocol for community-acquired pneumonia. Usually it's ceftriaxone and doxycycline. We shy away from azithromycin because of the mention of it, the over mention of it in the treatment trials. And that said, the therapeutic under trials, be it chloroquine, remdesivir, Caritra, or Abidol, are not in our standard guideline for treatment. So we have not used them to treat our patients with COVID-19. However, we are very open. We are very open to the conversation. When we heard about the Solidarity trial, we had engaged with our colleagues at the WHO HQ, and we have initiated the processes to register the local trial that would consider the use of these therapeutic under trial. And going forward, probably we'll be looking at the use of remdesivir mainly. Our discharge criteria: once you are in the treatment center, to leave the facility, you are again tested for PCR, and we are looking for 2 consecutive negative PCR before you leave. And specifically, we look at your CT value must be over 40 for the E gene and RP gene, which are the specific gene for this COVID-19. If in the process of being discharged, you are facing like you are negative, then you come back to positive or presumptive positive, we have to restart the cycle until we find 2 consecutive negative RT-PCR test results. Our experience with the patients in our treatment facility, our patients with COVID-19 are staying on average 18 to 24 days. As for follow-up, we have a follow-up plan at 2 weeks after leaving the treatment facility. We have a follow-up at 1 month and at 3 months. And at each of these follow-up, we do basic lab, basic hematology, basic chemistry, and also we retest the RT-PCR, see if we have any relapsing disease. And we were very strict about it in the beginning, because if you remember, as we are responding to the threat, other countries were also mentioning of possibility of infection or possibility of reactivation. We don't know in the end how the conversation ends. So we have a test, we have a PCR test in also a post-discharge follow-up plan. And post-discharge, we'll be screening the 4 gene to detect the N gene and open reading frame 1. And once it is positive, we submit the sample to E gene and RDRP screening to see if there is a a reinfection versus a relapse. Our epidemiology data, if you scroll into it and you review what has been the journey for us, you will see that it is the same for other countries as well. We have seen, most of the countries have seen that the disease initially was imported from overseas, what we call maladie d'importation, and we had early lockdown, like it was the case for many other countries. And if you see at the peaks that were around the national lockdown, you see that we had a number of cases, and here it was mainly returning Rwandans who were in the Middle East, those who were in Dubai, or returning residents. They were given a window opportunity to come back to the country because the airport was still open, and also the nationals of other countries who wished to leave the country to go to their country were enabled to leave. So thereafter, when the lockdown was implemented, we could see that the problem was significantly under control until in the mid-April, when we found a second problem, which was related to the truck driver. As you see, we can have a country under lockdown. By the end of the day, you need to see what do you need from outside. So you cannot let the population die of hunger, which would create a much bigger problem. So as you see, Rwanda is a sandwich, if I can say. It's located just in the heart of Africa. We import our goods from the port of Dar es Salaam, and it comes by truck to Rwanda. It can also continue to the Democratic Republic of Congo or go down to Burundi. So we are a corridor to allow these truck drivers to operate on the country. So it came with the consequences because it did come up with peaks of disease in the mid-April, and a lot of negotiation has taken place to see how to address that. We have tried the transshipment, we have tried to exchange drivers, which was not very much welcomed by the truck drivers. Actually, they say that for a professional truck driver, the truck is like someone's wife. So you cannot give the truck driver to someone else because of COVID-19 threats. So it was not very much accepted. And in the end, we have to keep innovating. As you progress towards June, you will see that we have, again, peaks. And this time, these peaks have a big burden of local contact of imported cases. This is the southwest border of Rwanda. It's a very active border that truck drivers use to ship the goods from Dar es Salaam, Tanzania, via Rwanda to Democratic Republic of the Congo. So you can see that also it is creating, it has made our southwest border neighborhood a hot zone. And because of that, the southwest of Rwanda is under lockdown again. As other countries progress towards the unlocking, this specific zone remains under lockdown. Data is key. We have a very fluid and user-friendly dashboard that is publicly available. It is updated on daily basis. It shows how many cases are confirmed. This was years ago. We had reached thousands of cases. It also shows how many contacts are associated with those cases. It also shows on the right column the number of recovered cases and the death and the active cases. It can also show the basic demographic such as gender, the age group. You can also find in this on this fluid dashboard the localities that are considered as hotspots or hosting the clusters for Rwanda. Also, we have this dashboard that will show you again the same information, but also it will go deep and show you how many of the contacts were able to be accessed, and those that were not accessed, what is the reason. Usually it's not accessible, there is a missing phone information. So this will be submitted to another level of investigation to try to find these contacts, use the existing investigation structure within the Rwanda National Police and others. It will also show how many of those contacts have already left the country, and we have the responsibility to inform those countries as well that so and so is the contact of a case that is confirmed positive in Rwanda because they share the same flight, because they share the same truck, etc. As you can see on this graph, our cases continue to increase, and we are also seeing an increase, a gradual increase in those recovering. So our recovery rate is around 50%, but our death rate remains very low. So far from the beginning, we have registered 2 deaths. This is the epi curve. Again, it will show the same information I just mentioned earlier. We have a hot activity in the southwest border of Rwanda. And this is the same again to reflect the main problem that I just mentioned. First, initially, it was the maladie d'importation. Then you had to address the local contact. Then you had to address the truck driver clusters. And now you're addressing a hot border that has to switch back to full lockdown. These photographs show one of the solutions we had implemented, trying to respond to the shipment of goods from the port of Dar es Salaam, Rwanda, or to the neighboring country. So all the truck drivers, because we do not want to interact directly with the population of Rwanda, they have to be given a police escort as they cross Rwanda to make sure that there is no direct contact with the community. They had to sleep at a very well designated hotels, and they had to be tested, and those who be sick will be taken to the treatment facility. Those who are not sick, they are allowed to continue the journey, especially if they have to cross Rwanda to the neighboring country, and we wait for them at the border, and we give them the same escort until they exit through the eastern borders, going back to Tanzania. And we are doing this on top of other innovative strategy. Surveillance around these hotspots also has been enhanced. We use the GPS to track the movements, and as we map the area, we also increase the area where the truck driver would sleep, where they would have escaped, and they had the brochette around there. So we will be testing the population around this site very, very much rigorously. Same as we have also IT support to map the area that are judged to be places of potential hot activity, like depending on what the job profile of our citizen. We know that the security guards are likely to be at the borders, are likely to be exposed. The construction workers, because these are facilities that are a bit crowded, to say with. We also have high occupation risk, like commercial sex workers, that would also be an emphasis on the surveillance work. And we use again GPS data to map the area that is carrying hot activity. We map the movements of the detected cases, and we will inform the police, we inform the government to take measures such putting such a village under lockdown based on the mapped area. Back to East Africa, Rwanda is the thirdest in number of cases. We really thank people, and we should encourage countries to share data openly. There is no secrecy about an epidemic. We can assist each other, and those who, you can see that some countries would stop reporting or sharing data as early as April, and many things will drive this decision, and we want we should be the one to encourage people to explain to people why should we share data, because this is not about a particular country. We have to think beyond our particular borders and come up with continental strategies. IT solution, again, contact tracing was phone call by a contact tracer to the suspect case. We are going to bring in more of IT solution to have this eased by using the WellTel technology. We can sit in a control room and do the same work and equally efficiently. Our laboratory is also had to be facilitated by IT solution, is fully automated from the sampling to the delivery of results by SMS or printed certificate. The turnaround time is about 8 hours. And we again screen for N gene, open reading frame antibody as a screening test. If one of the gene one of those two genes is lighting up, then you are putting the sample on the E gene and RDRP, which are most specific to the COVID-19. And on the report, we also include the CT values to allow yourself to tell, is it an infection that was easily detected by the PCR? CT value is like a cycling time. Was it difficult for the PCR to get the virus? And we are trying to see how to correlate the CT value with the viral load. We have all failed. We don't have this correlation. Looking at the CT value and come up with a corresponding viral load, a lot of work still to do. We also use a mathematical algorithm to track the movement, or to track the positive cases and the cases that are around them. So this is how we generate our list of contact of cases. Apart from what the names that the patient will tell you, we will also use this technology to detect those cases that are contact that the person is not able to remember. It does also allow us again to track the movement of the population. It's really, it has a lot of functions that has been very helpful in the response in Rwanda. And we have recently been joined by these guys, the robots, to minimize the risk of exposure of health providers. The robots can screen the temperature. They can patrol the selected area to see if people are wearing their masks correctly. They can diffuse educational information. So we are very open to IT support, and we are very privileged to be able to access this technology in our treatment center. On the right, we have a bracelet that we can put on the people that we consider as suspect, and see if they would be able to stay at the designated quarantine. Either if we had to decide tomorrow that people can do home isolation, we will have to base on this data, like how much % of the people we had given a bracelet did stay where they are supposed to stay. If this number is not interesting, then we are not looking into home-based quarantine or isolation. We might continue, we are likely to continue with keeping the suspect and the confirmed cases in designated facility. Common challenge, we cannot yet tell what are the circulating strains of COVID-19 in our region. This is very important for us who manage cases, because movement of the people will also inform you how best you should manage. And if we see a particular movement with a virulent strain, then it will inform the policymakers, it will inform the countries, it will inform the future how best to address this problem. And again, to end with this quote by Peter Piot, epidemics on the other side of the world are a threat to all of us. No epidemic is just local. There is no need to score the performance of a particular country. We should see beyond, again, we should see beyond borders and see how this region is doing, how this continent should do. Like, we should come up with our best fitting regional and continental strategy. On that note, I thank you very much for the privilege given to Rwanda Medical Association to present on this forum. Thank you.
Very much, Dr. Nkeshimana. Again, I think that the Secretariat of the Commonwealth Medical Association did an excellent selection of experienced people, who are also passionate about what they are doing. You shared with us the structure, the coordination structure of COVID-19 response in Rwanda and the Epidemiological Operations Center. And of course, we learned from you that 80% of the patients experience an acute stress reaction requiring the intervention of psychologists and psychiatrists. Well, I think that the experience in Nigeria is not that high, but maybe attention is not being paid. We need to find out during question and answer from Dr. Boale. 40% of the cases in Rwanda are symptomatic.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.
That is that in Nigeria, the length of hospitalization is currently about 12 days. And I don't think that they rely on 2 consecutive negatives now. I think they discharge on 1 consecutive negative, and that can be up for discussion during question and answer. So I must thank you for your presentation, which has been passionate, and then of course demonstrated that lockdowns do have effect on the pandemic, and then of course the effect, the challenges that your country faced, serving as a transportation corridor. Thank you very much once again, and we hope that you stay on to welcome questions. It is my pleasure now to invite Professor Dhruva Chaudhary, Professor and Head Pulmonary Care Medicine, and he was awarded the prestigious Commonwealth Academic Staff Fellowship in Pulmonology in 2009. He's also a recipient of the Ansraj Nair Memorial Award of the Indian Society of Critical Care Medicine for Best Researcher. We now invite him to share with us the experience from Asia. Professor Chaudhary, you have the floor, sir.
Yeah, good evening, everybody. I hope I'm audible and my slides are visible.
Excellent. Your slide is audible. Your slide is visible and your voice is audible.
Thank you so much, Dr. Akin. Now, it has been a pleasure actually listening the experience of managing COVID-19 from Africa, from Caribbean, and now I'm going to give you a bit of a perspective from the Asia and particularly from the India where we are going through this epidemic. And next 15 minutes I shall be discussing about it. And I'm also grateful to Indian Medical Association for giving me a chance, because this epidemic which has come up to us has been targeting a couple of major cities, including our capital Delhi, also our financial capital Mumbai, earlier a city of Indore, as well as in city of Ahmedabad. And they are a very densely populated city and has created a unique challenge for us. Therefore, Alex has said it, either you deal with what is the reality, or you can be sure that the reality is going to deal with you. I think that's an extreme prophecy, which is true for COVID-19. When you start looking at the story of COVID in Indian subcontinent, first of all, the first case we reported here was on January 30th. That was from the state of Kerala. These were the young people who had shifted from China and who were studying there. But nevertheless, we had seen 3 cases at that time, all in the city of Kerala, and it's a huge country. And right from Delhi, it is roughly around about 3,200 kilometers. But nevertheless, it helped us waking up our public health responses. And that was one of the major reasons that we saw 3 waves which came to us from China, from the Western Europe, and later on from UK and USA. We were able to handle it, but somehow, somewhere in the middle of March and April, in beginning of April, we did lose some control. And there's just so much of variability within this country. Kerala and Goa still continue to do extremely well in India, whereas in Mumbai, in Delhi, as I said, in Gujarat, we are facing quite a lot of problems. When you start looking at the statistics, we are a huge population and a density. You look at it you compare to USA, Spain, Iran, we are nearly to them roughly around about 10 times. Therefore, for us, major challenge is how to take care of and prevent the spread. And if this illness goes into community, how to take care of the deluge of the patients if it come up, because even the best of the centers in US as well as in Italy, they found it wanting in spite of best infrastructure which they had. So that has been there, which you see. If I look at the current scenario, that is till yesterday, we have roughly nearly 6 lakh cases, and we had 17,000 deaths, which have been reported from various parts of the country. But dominant again is coming from the city of Mumbai and followed by the city of from the state of Gujarat and partly contributed by Delhi. In this case, if you see the various zones of WHO, primarily we are looking at Southeast Asia, and we have more than nearly 8 lakh cases which have been reported. And some part of Western Pacific just come up, especially if you see it in this case, there will be Malaysia, there will be part of Indonesia, Philippines, they're also covered. As far as in this case, Eastern Mediterranean is concerned, Pakistan comes into that, and Afghanistan comes into that area. But geopolitically, they are part and parcel of Asia. There again in Pakistan, we are seeing an upswing, which is there. This is the growth of COVID-19 in Southeast Asian countries. If you see it here, if you see the countries which have been successful in flattening the curve, which was shown so elegantly earlier, one of my speakers have been in Sri Lanka. In Indian context, we have been able to take care of the beginning. And again, when you see the doubling time, it went up, and you are seeing a peak which is coming up, which is little flare, which is steeper, but still not as steep as what we saw in Italy. And the doubling time in India as of today is around about 17 days now. The same pattern has been followed by the deaths, which you see, whether it is in Sri Lanka, has obviously minimal number of it. We are seeing a large number of deaths which are coming up. That's why the gap you will see is going up. But other countries also are seeing an increasing mortality with an increased number of cases. But what is reassuring to us is, if you see it today, in the world, we have nearly 1 million, you have got more than 10 million people who are suffering from COVID-19. But and the deaths have been nearly 5% or so. But here in Indian context, if you see it, if the 5% is the mortality in the worldwide, we have 3% mortality. And again, it is varying from different parts of the country. Now, this is a huge country, and if you see it, the city in the state of Gujarat, we have more than 5% mortality, and there have been increased mortality in the states of Maharashtra and Madhya Pradesh, which are the very big states here. But dominantly, again, if you see, it sticks around to Mumbai. But the good part is that we are also having a nearly 60% plus recovery rate is there. And the cases per population, when we started looking at it, India still has got per 1 lakh, only we are seeing roughly around 21 cases. That means the lockdown which was done in this country, which was unprecedented, I've never seen in my 50 years, 55 years of my life, never seen it ever. It has made a huge difference in terms of delaying the peak and also blunting the peak, as probably we would have seen it. Similarly, you look at the deaths per lakh of population, it still continues to be much lesser than what you have seen, whether you have seen it in the UK, you have seen in Italy, Spain, or even in the USA. So probably the public health measures, which are very strictly taken by the government of India and also equally supported across the political spectrum by the various states, because the states itself are sometimes the size of countries in this big nation. And people have been talking about, in the Western world in particular, about the deficiency of doctors in our country. Yes, there is in totality, if I see the doctors' distribution is less. But when we start looking in terms of distribution of it, probably there is a skewed deviation. So they're more concentrated in the cities and rural areas there. And the good part, as far as in the country, as of in India today, is what we are seeing is the spectrum of COVID-19 we are seeing in the places where we had a very high incidence of swine flu, that is the urban area. I can give you a comparison. What is happening in the Delhi, in the cancer patients who are getting the cases, 20 to 30% coming positive in certain hospitals. But when I look at my regional center, which is catering to nearly 500 to 600 cases per day, we only have 2 positive. And probably when we looked at the difference, it is realized that predominantly in India, still the disease continues to be urban rather than passing on to rural area. Similarly, we have been also talking about the beds, or critical care beds, 2.3 per 1,000 population. But if you see it also, United States, Italy, which have a very large population, large number of ICU beds, still they had a challenge, because this is what we had started looking right in the beginning from. Because if there is a deluge, there is a search, we calculated, we did a mathematical modeling, how are the number of patients are going to. From the Western world, we calculated that nearly 30% people will be symptomatic. And out of 30% people, if we look at it, there will be probably, out of these 100 patients, 10% may be requiring oxygen or ventilator. That's how we calculated. But still that number, because of population, is like a city of Delhi, which is a population nearly of 2 crores. You will see 20 million, the number goes jack up. And that is the reason people talking about 2 million to 3 million cases coming up in Delhi over a period of time. But fortunately, we are seeing increase in the number, but till now we are holding on. And by and large, there has been a challenge for us to critical care beds, but the government has expanded. The private sector has also come into it, which is taking care of it. But yes, definitely, we have some shortage. So we are trying to provide in the National Capital Region a strategic depth, same as happened in Mumbai as well. We talked about the number of ventilators, and I know there has been talk about less number of ventilators. I go by the thing, what you're seeing in Italy, what you're seeing in UK, or what you have seen in USA, particularly in New York. The mortality of the patients who have gone on ventilators have been very high. So probably this something has been very skewed. I was discussing it with my colleagues in UK, and we have written a commentary for one of the major leading republic, where we were talking about what use is when you do not have a basic infrastructure, or people who do not know how to use ventilators. Therefore, what we realized at that point of time is that it is the oxygen supply which is far more important than actually your ventilators, because majority of your patients will be needing oxygenation when they land up in trouble, rather than looking at the ventilators all the time. And we have been trying in this country augmenting oxygen supply vis-a-vis demand, which is there. And obviously, we have a very diverse system in this country of cylinders, manifold systems, concentrators, and liquid oxygen. My own institution, we have 3 different liquid oxygen plants to supply and to supplement it. The government, and we have done it, more than 1,000 D-type cylinder. That means we have created, if we look at it, each cylinder roughly equal to more than 10 KL capacity. We have created, as far as the mobile liquid cylinders, we have also done it. So that if some problem occur, we do it. So that's a very big challenge which was taken by the health administration across states as well as the government of India. And probably, I think, we have diverted a lot of this oxygen which was in the industrial area to your medical oxygen. And this gives you an idea. When the epidemic started, India hardly used to make 25 to 50,000 PPE. Today, as of today, within 4 months of it, we are manufacturing, as of today, per day, nearly 2 lakhs, which have been expected to go up to 1 million per day. Initially, we had an issue of quality, but today, I can vouch with you, within the span, the way the industry has changed, we are finding a large number of PPE that the government has given a confidence to the government of India that yes, we can go and export. Same has been true not only for the coveralls or the wrap-ons, but same is true also for the goggles, for the face shields, as well as also for the N95 mask. Same has been oxygen cylinders. So these 3 to 4 months has given us a huge time to do it. It may not be sufficient, but it has given us enough confidence to deal this. When you start looking at the best practices, when we started as far as the diagnosis is concerned, a lot of my friends have talked, but we have all the facilities today for molecular detection, antibody detection, as well as antigen detection. Antibody detection, we have left altogether because of the kits which we got it from various parts. They did not do very well in the field testing. Molecular detection is the mainstay. And when we started, we just had the capacity of 10 to 15,000. Today, we are doing more than 3 lakh tests a day. In my own state, which is surrounding state of Haryana, when we started, we had 2 labs. Today, we have, as of now, 12 laboratories having a capacity of doing 10,000 RT-PCR per day. Same way, antigen detection has come into picture now. It is undergoing field trials. And what we are seeing is dominantly we are doing RT-PCR. Similarly, we have now looking at the TrueNet and CBNet, which again are things which are being used for the TB diagnosis. They have been now diverted afternoons in terms of diagnosis. So what the strategies we are following it up and is, I will come to that later, but if you see today, as of now, we have 1,047 operational labs having a capacity to do nearly more than 2 lakh tests a day, and it is still being augmented every day. Like in my small state, we are going up to a level of doing 30,000 tests, and today I can say with a sense of pride that we are done more than 10,000 tests per 1 lakh people. So we are going very strongly on it and picking up the cases. There are challenges there everywhere, but government has come up very well, and we have upgraded the lab skills as well as the lab infrastructure in our country. Obviously, when you start looking at antibody detection, I told you that the rapid antibiotic tests were a failure here, but we have now got a camelosense test, and we started detecting, quantify immunoglobulins. Myself also went through a COVID. I had a COVID, and today I got my antibody tested, and I can say, yes, I have got a pretty good titers now. And we are using in serosurveillance, which has started, and the serosurveillance, which was done in the month of May and April, it clearly showed us that, yes, there is a challenge, but what we found, except for few areas which I discussed to you, still we are not having community transmission. Primarily, it is in the cities of where the metropolitan areas where we are seeing some evidence of community transmission. But when I go to the rural area, still we are not finding it. So what we are doing today is, ladies and gentlemen, is we are first now making a plan, which has been, ICMR has also proved it and has come up with a revised plan. We are going to do an antigen test. If it is a positive, we are going to take it as a COVID case. If it is a negative, depending upon the urgency which is needed and required, and the urgency will be an emergency surgery, labor rooms, and sometimes we are facing any issues with the dead bodies which are coming up. At that point of time, we will be using CBNet, TrueNet, and results will be there. And no urgencies, we are going with RB-PCR. CT chest, we are not put into any algorithm, but I think what we are trying to do is anybody who is sick for 5th to 7th day and has a cough or desaturation on exercise or after doing activity, we are taking them up. And we are extensively now, at least in the private sector, but in the government sector also, and the public sector, we have started using more and more CT scans to pick these cases early. As far as the best practices in the treatment is concerned, obviously, if you all aware about the timeline, we are following this now, because what we have realized in India from the literature which we had it with our own experiences, it is the timeline of COVID disease which is the key. So once you have an exposure, you have an incubation period, you have an onset of symptoms or pre-symptomatic phase, it is important for us to realize to pick these patients early. So it is the 5th to 8th day. When you start getting immune responses, that is the time we are seeing large number of people are having a problem. Catch hold of them, look at the cytokine storm, treat it, and if you are not going to do it, death is going to be there. Again, I'm sharing experience of this. I will come to that. When you look at a COVID-19, I am putting my neck out and saying it's a steroid responsive disease, and the timing is important, because in the initial phase, it's a viral replication, and later phase, it is immune dysregulation. And what we are doing is that in these cases, we are trying to keep them young. And I can give you an example of my institution where I'm practicing. Till we started practicing this, we had 27 deaths. But since we started multidisciplinary rounds, and we're looking at it more vigorously, in last 3 weeks, we only lost 5 patients. And one of the major differences which we saw was the use of steroids, whether it's a methylprednisolone or dexamethasone, we have been using it at this point. And also, we have been very commonly now, we have used tocilizumab in nearly 60 patients, which is an IL-6 inhibitor. And we found where we give it early, only out of 16 patients where we gave it, 2 died. But again, that we are going to come up with our data. That is what we are using with. HCQ has been taken away from the moderate and severe, but in mild cases, yes, we are still using it. There have been other drugs like ivermectin, etc. Favipiravir has been approved, but we have a very little experience as of now. Vitamin C, zinc, people are using very regularly, and also the traditional Indian medicine. And managing hypoxemia for us, we were fortunate enough that we don't have to struggle that, but yes, there was a learning curve. And what we are using predominantly, we are using in these cases, high flow nasal cannulas, non-breathing mask, and if need be, CPAP and NIV, primarily with the full face mask, and when helmets are available with it. And obviously, awake proning is become a rule than an exception with us if person is not doing well for us. Convalescent plasma therapy, this is a young boy who just donated us the convalescent plasma. It has been approved for the compassionate and emergency use by a ministry, by the government of India. And we have nearly collected 600 data is expected anytime from the ICMR study. And whatever the little bit offhand I have an information, it has been found to be promising. And the Mayo Clinic data, which was published, also said that it is safe to give it. But nevertheless, what is the biggest challenge is to do specific immunoglobulin levels in these cases. So what we are doing today, my dear friends, is that we look at it whether the patient is asymptomatic or minimal symptomatic without breathlessness. We look at the CXR if the person is in the hospital and look for oxygen saturation. They are being regularly put on home quarantine, but with a very intense pulse oximetry. That's what we are doing it. And we are using digital technology of an Arogya Setu, which is an app, which is mandatory like a wristband, which was shown to by our previous speaker from Rwanda. And if there is a problem, they are pushed back to the hospital. On the other end, as I said, we are monitoring the inflammation very closely. We have built up our capacities and still in the process of building up. And wherever it is there, we are using steroid at the first line, followed by plasma where it is available. And obviously, sometime in the trial or otherwise, we are not hesitating in using tocilizumab. On the other hand, antivirals, remdesivir was not available to us. We were using a combination of lopinavir-ritonavir. We added ribavirin now. Remdesivir has become available, and we have used in now 3 cases, at least in our institution, and now it is becoming readily available, and we will come up with the moderate disease, what is there. As a president, we had written the position statement. This has become the mainstay along with ICMR in most of the intensive case setting, the protocol which we are following. Home isolation I picked up. As I said, it is a supervised through, we called as an Arogya Setu. It's an Hindi application. And breathlessness pulse oximetry we are giving everybody. Every day we are calling these patients twice a day so that we know something is not going wrong. And any person who has got a breathlessness, fever, and cough is being asked to report. Therefore, what is important for us is an ounce of prevention is worth a pound of cure. That's what Benjamin Franklin said. So adequate PPE, as I talked about, the biggest challenge I'm finding is infection control practices. But I hope this is a universal thing throughout the world, and we need to keep on reinforcing it. And this is something which is very different from the word data. We people have been on hydroxychloroquine for prophylaxis. I myself was taking hydroxychloroquine. And what we are showing here in this data, if you see it in the ICMR, which has been public domain now published, that it starts becoming effective after 4 weeks of therapy. And I will be very happy to answer any question of it. And again, the people who are taking it, it's not saying that it will take you away from the infection, but probably it will reduce the complication which you are seeing are responsible primarily for the death from SARS-CoV-2. The challenges are the population. It's the poor awareness sometimes about the people, especially the poor, even if they are aware, because of the day-to-day things which are required for their livelihood is a challenge. Unemployment has become a very big issue with us because of job loss, migrant workers, transported jobs. Challenges are preventive. We are already going for a vaccine. BCG trial is there, mycobacterium trial is there, so is MMR. But vaccination, we are going to start trial from next week, which is a whole killed vaccine viron, which is there. Let's see what data comes up. Phase 1 is going to come up, and 10 centers have been identified, and we are going to recruit patients soon. But the most distressing part of it is the stigma which has been associated with it. And the net result is that people are concealing symptoms. They have a hesitancy in seeking medical care, and they're not adhering to intervention, and we may have to use sometimes forceful measures. So that's a very big problem of stigmata and discrimination. So when we looked at the medical professional, you will see nearly 1/3 were depressed, 40% were having anxiety, and 1/3 was stress. And I'm sure this must be throughout the world. And that is where the article, this was published in European Heart Journal, which talked about lessons from Bhagavad Gita, from the land of Gita, from where I'm speaking to you is actually from there. And what they say, which is important for the medical professional, is to be able to do what is needed without becoming attached to the result is the way of living a skillful life. And that's we are trying to practice it, telling our healthcare workers to come because of the scare and the panic, there was a lot of confusion to manage these cases to begin with. And again, this is an article which has been published in Lancet. With today's crisis, what Gandhi would have done it, he would have begun with actions which were initially small. So we need to look local, we need to look small. I'll start working from there. We need not merely preach, but we need to act and practice ourselves. We need to act locally, not chase the world to change. And I hope it is important everywhere. This is a young girl tenure which made as a part of collage, which signifies what we are practicing in this country. We are asking people to stay home. We are asking for quarantine. We're trying to tell you, build up new things, new ways. And I would like to acknowledge quite a few people who have helped me in making this. Dr. Rajan Sharma, President of Indian Medical Association, and people from Ministry of Health, my own university and faculty and fellows of pulmonary critical care medicine. Thank you very much for patient listening.
Thank you very much, Professor Chaudhry. Again, another very...
Insights from the world's best medical minds. You are watching TheRightDoctors.com.
health measures that India put in place, and the lower number or relatively lower number of cases per population and the lower mortality rates are also probably due to these public health measures. And of course, in India, only a minority of cases require oxygenation from your presentation. But despite that, India seems to have a very robust oxygenation plan. And you highlighted the various strategies for oxygenation that India has put in place. Of course, molecular detection remains the mainstay of diagnosis in India, and you advise that rapid antibody tests are not recommended, though rapid antigen tests are now being validated. Finally, you emphasize the role that stigma has been playing in this outbreak and the psychosocial effects of stigmatization on the health workers and on the cases. So we thank you for putting time at our disposal, for preparing your paper, and for eloquently presenting it. I think now we are ready.
Thank you, Dr. Akin.
Yes, thank you very much. Thank you. So I think we have just one more paper, and that is by Dr. Tenabulele, President CLA.
David, yeah, thank you very much. The last presentation is by Dr. David Strain, who, of course, is from UK and is the chair of the BMA Committee on Members' Relations. And he is here to so eminently make his presentation to us. He's very conversant, especially with care for elderly. And of course, he's been, since March 2020, he has been leading a COVID-19 response team for older adults at the Royal Devon and Exeter NHS Foundation Trust. So he's very conversant with COVID-19 management. And like I said, he's a senior clinical lecturer at the University of Exeter Medical School, and also an honorary consultant in medicine for the older adults, and the co-chair of the British Medical Association's Medical Academic Staff Committee. So he trained, schooled, and of course, even did his postgraduate in the United Kingdom, and very conversant with the COVID management, particularly in the elderly, which is also a very important group of individuals that we also need to pay attention to. So with your permission, Mr. Moderator, may I respectfully call on Dr. David Strain to take the stage to make his presentation. Thank you.
Hello, can you all hear me? I will take the silence as a yes. So thank you very much for the opportunity to come along and talk here. It is a great pleasure to be part of this august collection, and it's been very interesting for me because as we've been going through this, I have been seeing several figures that were all showing the very same thing, the way that the UK has been doing compared to the rest of the world. These are the figures, and it's not good reading. It's probably for the first time ever that the UK has been on top of a league table absolutely anywhere recently. And it's not the league table we want to be on top of. We have more deaths per head of population than just about any other country within Europe and any of the countries that we've seen demonstrated here. And even within that, although we started much earlier than many of the countries that we've seen, basically, we don't have, we're not even out of the woods yet. You can see here that the cases that we're experiencing in the UK are not, the cases that we're seeing in the UK are not going away at all. The cases in the UK are still continuing to go in a flat race. And one of the things that we are very concerned about at the moment is that we are likely to be seeing an upswing in those cases as things are changing. So these are all of the elements that we have been looking very carefully at in order to try and figure out what we are doing wrong. And when we look at what we're doing wrong, it's quite easy to see some of the figures. On the 13th of March, when COVID started hitting across Europe, this is what Germany looked like. They went into lockdown. Everybody went into isolation. It was a voluntary thing done by request of the government. On the very same day, this is what the UK looked like. On the 13th of March, 150,000 people gathered in one event to watch a horse racing event. If you look at Germany today now, the lockdown is easing and people are going back to some degree of normality. This is the population that the process is going on. Masks are being worn by everybody. Social distancing has been maintained the norm. Today, on my way into work, I went in and took a quick photograph of the shopping that is going on within the UK. They just haven't learned. And I do blame a lot of this at central government and the lack of leadership that's being maintained. However, one of the advantages, if you want to call it that, is within the UK, the research establishments have been able to do a lot more of the development, a lot more of the discovery about how this can be tackled going forward. So I've broken my presentation down into 3 parts. The first is going to talk about some of the mechanisms that we've been working on in the UK. Then the second is going to talk about some of the bits that are going on. I'm seeing comments on the side that, are we seeing a slideshow for my presentation? Do we actually have a copy of my slide?
Yeah, we are seeing your slides. We are seeing your slides.
Good, good. Okay, sorry, I just saw the element going on in the sidebar. So the bits that we've learned have been a lot about this coronavirus, and you've seen some of this before. I have modified my presentation as we've been going through because I want to minimize the amount of repeating that's gone on. This is the coronavirus, the virus with the crown. That's where it got its name from. And what we've already seen is how this is interacting via its spike protein with the ACE2. Now, many of us will have forgotten what ACE2 did from our basic training, but the ACE2 is actually one of our protective pathways. It is involved in conversion of angiotensin 1 through the Ang profile to actually prevent atrophy, prevent fibrosis, reduce inflammation, and have an antioxidant. And actually, in any acute vascular event and also in a sepsis event, ACE2 is upregulated as part of our protective strategy. Now, when we look more at the other things that happen when this is inhibited, we know that the spike protein breaks into 2 and leaves 1 element here to inhibit the ACE2. The other thing that does become upregulated is ACE, the angiotensin converting enzyme that we know so much about, that's involved in tissue injury, particularly around heart failure, particularly around an acute respiratory distress, and around these microemboli that's been going on. And we know that after the virus has used this ACE2 to enter the cells, we are not just seeing the impact of the virus, we're also seeing the impact that this ACE2 is left completely blocked. As a result, our body loses its ability to protect itself. And the processes that's trying to protect itself, here we see an upregulation in the tissue injury, and that's causing a lot of the sequelae of the COVID that we're hearing about. We've learned a lot about the viral biology. It's very different from many of the respiratory pathways, that its main mode of transmission is through the endothelium and neurological. And it appears to be hanging around significantly there. We are already seeing our first signs that the evidence of the 1918 flu pandemic, where we saw a Parkinson's-like disease appear afterwards, we're already seeing the first signs of that occurring here. Another element that's taken, and I think everybody has already alluded to this, is this prolonged incubation period where you'll get at least 5 days of negligible symptoms. And this is the asymptomatic vector period, but these people are highly infectious, and that's why the lockdown has become such a key element of maintaining the protection of people, and why this 14-day quarantine period, which is the 14 days until people will establish the symptoms if they're going to get them. That's why this 14-day quarantine period without symptoms is so important to all these tests and traces. Another element that's become apparent through the COVID tracker app that we've been using in the UK is that the first symptoms that we get within the first 5 days are not the symptoms we typically expect from a respiratory virus. We get a generalized fatigue, we may get fever, we might get some diarrhea. And actually the key symptom that we observed in the UK was this anosmia, the lack of taste and the lack of smell that we see. By the time people present to hospital, what we see is a very different picture. The fever is by no means ubiquitous. Only approximately 2/3 of our patients will have fever, and this is intermittent. The lack of fever by no means excludes the diagnosis of COVID. Similarly, breathlessness is not common. For the majority of the older patients that I've been treating, they've had hypoxia with oxygen saturations in the high 80s or even low 80%, but they've had no symptoms whatsoever. The respiratory rate has been completely normal. A cough is common, but sputum is only really present in the coexistence of COPD or other conditions that are associated with sputum. We've seen that GI disturbance is a very common feature in our frail elderly population, and indeed in the elderly population, the GI often is a main indicator. Now, one of the issues that we've had, like many of the others, is there's just been a complete lack of a robust test. The testing for it, based on the RNA and the PCR, only gets about 2/3 of people who have the virus. And even if we come later on, many of them will not test positive for the PCR. The antibody testing will get people eventually, but clearly a test that is only positive 14 days after presentation to hospital is completely useless. So in order to diagnose people, we've used a whole battery of blood tests, and these are not the typical blood tests that you'd expect for respiratory infection. One of our hallmarks is the low lymphocyte count, and this is probably mediated through the SCL1 receptor on the lymphocytes that suppresses the CD4, and we've already seen some cases where this has been the case. But with the low lymphocyte, this is a very non-specific marker. And the low lymphocyte count only becomes relevant if it's accompanied by a raised liver function test. In the first few weeks, what we saw were 5 times elevation of AST and ALT, and we got many of these patients an ultrasound which revealed absolutely nothing. Many of our patients get rhabdomyolysis, and their CK is almost always high for our patients. Similarly, the troponins will be elevated, and this is in the setting of a normal ECG. We believe this is due to the widespread microvascular occlusion caused by this breakdown of the ACE2 enzyme. The CRP may also be elevated, but again, this is not always the case, and it's very rare for it to be very high. So what we then have is this catalogue of a low lymphocyte count, raised liver function test, raised troponin, raised D-dimers, and that's been our main way of prognostication. And we have seen a very consistent pathway in the treatment of our patients. And this is something that we've managed with the way we've split our patients. In phase 1, there is a viral disease, and this is similar to any other viral disease. Now, within our department, we've done a lot to separate people at this stage because the viral disease in the youngsters, remember, I'm a geriatrician, so as far as I'm concerned, anybody under the age of 70 is young. So it's a mild disease for youngsters, and it's very rarely that these people require additional help. For our frail elderly population, actually, this is the part that's killing them. They are getting a very significant flu-like viral illness that has a much higher risk of superinfection. About 22% are complicated by a fungal infection in our experience. And so for our frail older adults, when they're presenting with this picture, we are routinely starting antibiotics because it doesn't appear to be the viral illness that kills, it's more the superinfection that kills. Now, for our elderly population, that tends to be the end of it. If they survive this period, they then will go on to a prolonged rehabilitation. And again, that's another feature. A standard rehabilitation for a frail, vulnerable adult would be for every day in hospital, it takes 3 days to regain their strength. With COVID, for every day in hospital, it led to about 5 days to regain their strength. And that meant our average length of stay was around the 24 to 25 days for our vulnerable adults. For our younger patients, however, they then would go on to an acute respiratory distress syndrome with a cytokine storm, and this is a very rapid deterioration. Now, it's important that we've identified that this is occurring at the end of the viral load. Early on, it was noted that people in ITU and doctors working in ITU and nurses working in ITU had a very low risk of contracting the virus. And it was thought that that was because they had enhanced PPE, that they all had the FFP2 mask with the screens, the visors, the full protective wearers. We now have discovered that the majority of patients who make it to ITU have a negligible viral load. And at this point, it's the cytokine storm that is killing people. And that's basically the upregulation of these interleukin-6, the interleukin-3, interleukin-17, those things that you've just heard about, at the same time that they've lost their protective mechanism. Our ACE2 pathways are completely obliterated that should be upregulated when we exhibit any of these ACE2 pathways. Our prognosis was very similar as we've seen before. Like the majority of countries, that we've seen a lot more of this in men than women. It's far more common in the very elderly patients, in those with diabetes and those ischemic heart disease. And that is actually a really quite telling comment, that it's actually in the ischemic heart disease, it's in the vascular complications that we've seen the bigger problems. Now, I'm going to take a moment just to cover an area that hasn't been covered yet, because I just want to talk about the COVID in the elderly. In the UK, when having seen the issues that had affected the Lombardy region of Italy and the fear that we were going to be overrun by this disease, we had a very rapid process of discharging our elderly people into institutional care, into residential care or nursing care homes to get them out of hospital. This was for two reasons. The first was to get them out of the place at risk, because we'd identified that they were the highest risk, but also to free up hospital beds in order that we'd been able to cope with the demand as it occurred. The problem is, many of these individuals had already been exposed. And we didn't know enough about the virus at that point to realize that for our older adults, it would be a 7 to 10 days. Then we have these people getting into the hospitals. What we've seen is that these people acted as vectors, took the disease to the nursing homes, and as a result, we have at least 15,000 additional deaths in the UK that were not identified as being COVID, but were very, very likely to have an underlying consequence within there. Within any of these sorts of institutions, we've now put systems in place that we have very careful rules for monitoring temperature, for oxygen saturations and documenting confusion. And in elderly patients, a key feature now is identified as delirium. So what we are faced with is this approach of we are isolating this as much as possible, but what we do have to remember is that we are dealing with a disease in somebody's institute. So I just want to come back to some of the more common features and more common problems that we face. And the first is diabetes. Diabetes theoretically should be a low-risk disease. People with diabetes have got a much lower levels of ACE2, therefore they theoretically should have a lower infection rate. However, what we have seen is that once they have the infection, they have a much poorer outcome. And we believe this is because the ACE2 is not there to protect them at all, and therefore once they get an escalated effect. The other thing that we've identified is that people presenting with COVID are getting a very atypical type 1 picture of diabetes, because the ACE2 is present on the pancreas and they'll get a complete pancreatic shutdown. And so forth, we are very commonly seeing in almost 5% of our population with COVID, massive spikes of hyperglycemia that requires insulin therapy. Another problem that developed early on was the ACE inhibitors and angiotensin receptor blockers. You see, we identified that this ACE2 was one of the key risk factors. And we also know that being on long-term ACE inhibitors was associated with upregulation of ACE2. And therefore, it was thought that this might accelerate virus activity. And a few early studies did suggest that people on ACE inhibitors had a higher risk. However, when we got down to it, that was not the ACE inhibitors that caused it. It was the underlying disease that caused this. And we now know that being on an ACE inhibitor is actually protective once you're diagnosed with the ACE. And therefore, we've got trials underway to find out if we use ACE inhibitors in our high intensity settings, does this actually reduce and have a protective effect? The same was seen with statins. You see, statins upregulate ACE2, and it was shown that people on a statin did have a higher rate of developing COVID, but once they developed COVID, the risk of vascular inflammation was lower, And therefore, all of our recommendations are now saying people need to continue on the statins. We've also had a very active research program looking at other things, and we know about the cautions. And it's good to see that all the nations are following the same pathway, that this ARDS is not shown, and therefore we don't need aggressive fluids. One thing that we are recommending in our elderly population is that they get antibiotics almost at that diagnosis, because we know that 50% of our elderly patients are going to die of the superinfection rather than the viral itself. By doing this, we've managed to reduce our mortality in our elderly population from being one of the highest in the country down to one of the lowest in Europe. So although we're not doing well as a whole, for our elderly patients, we are protecting them. We've recently reported trials with remdesivir, and what we've demonstrated is it reduces viral load dramatically. It reduces the infectivity of an individual who's got coronavirus. However, it had no impact on mortality or the ITU stay. Given the expense of the drug and the difficulties in accessing this, as a result, we are not using this at all, given that the only thing it appeared to do was reduce hospital stay by about 48 hours. In the recovery trial, we've managed to do a randomized controlled trial looking at the effects of hydroxychloroquine in the treatments. Now, I stress this is very different from our last speaker, from Professor Chowdhury's report, that hydroxychloroquine at preventative. This is in the treatment of COVID. And what it demonstrated is there was no significant difference at 28-day mortality. Actually, the hazard ratio was on the side of harm, although this was not statistically significant. And this was probably because we saw an upregulation in the dysrhythmias, the cardiac dysrhythmias that are known to be associated with a hydroxychloroquine in the setting of a disease that does adversely affect the heart anyway. We've also very recently, only 2 weeks ago, reported the results of the recovery trial. And what we've demonstrated is that dexamethasone at 6 milligrams once daily, although it gives no benefit at the outset, is associated with a reduction in the mortality. So this is at the outset. And you see here that if you give dexamethasone from day one, it was associated with an increase, although not statistically significant, in the adverse impacts. However, when we looked at it in those who required oxygen or those heading towards ITU, what we saw was a reduction in the mortality at 28 days. So on the basis of this, we are very strongly advocating dexamethasone at the time that patients become sick requiring oxygen. But we are very strongly giving the public health message that this is not a treatment. And actually, when it's given in early diabetes, in early patients with the disease, what we may be seeing is an increase in the total risk. So it's very important that our patients don't access dexamethasone and don't start giving this themselves. Also important to be aware, because of the high rates of diabetes, 23% of our population who've got COVID have got diabetes, that what we also need to do is be very cautious about our patients with diabetes, because they will require further insulin requirements. Other strategies that we're looking at, and we are still investigating, like Professor Chowdhury was intimating, we're still investigating the use of hydroxychloroquine as a prophylactic, because that prevents the endocytosis of the virus, and therefore prevents its ability to get the RNA into the cell to start replicating. We're seeing the use of Arbidol, which is also giving the same prophylactic role, but it's important to say that these have only got prophylactic potential. We're looking at other antivirals to see if we can reduce the progression. However, given what we now know, that this is a disease that doesn't cause issues from the virus itself, but for the younger population, causes them in the autoimmune response or the exaggerated cytokine response. Our main effects now is looking here at things that are looking at interleukin 6 or interleukin 17, or things that can mitigate this. And that's things like the sodium thiosulfate or the dexamethasone, which now has confirmed benefit. Now, With my other role, I work with the British Medical Association, and one of the things that we are very keen on here is we need to protect our doctors. And it's been well established that the mortality of a healthcare professional almost anywhere in the world working with this COVID, one of the things is a 5-fold increased risk of mortality amongst healthcare professionals. And that's even after the use of appropriate PPE, the glasses and the visors and the masks. So one of the things with the BMA we've been looking very carefully at is what are the biological predictors that will look at an adverse effect. And one of the things that we've seen is there are a few key parameters. So it's no surprise that the older an individual is, the higher the risk. Within Europe, there's been this key where we see an almost doubling in risk with men compared to women. And I do accept that this is different from what was seen in previous populations. We've also looked at the composite risk scores of multiple comorbidities. And we know that around 75% of the deaths have been in people who've got multiple comorbidities, and 95% of the deaths in Europe have been people with at least one comorbidity. So as a result, what we've looked at is all of these comorbidities within individuals, and we've been generating risk scores. And the point of this is enabling many of our healthcare professionals who are at the highest risk to move away from the front line of dealing with COVID. There are many other roles going on within the hospital at the moment in order to resume normal services. We've got remote clinics, we've got triaging, we've got clinics in green zones with people. And what our aim is to generate a simple risk stratification tool that's enabled us to protect our individuals, our people who are working with our COVID patients, in order to risk minimize their ability to do this. And what we are now recommending as of today, we're pushing this tool out across the whole of the UK for all healthcare professionals. All of them will be risk stratifying themselves based on this very simple stratification tool, where they give themselves a point for each of the risk factors that is associated with each of these things. And there are many reasons why each of these are occurring. For example, we know there is a different degree of ACE2 within different populations. People of West African descent have got a higher level of ACE2 than people of European descent, and therefore have a higher risk. We've got different diseases. Heart failure carries a much higher rate of ACE2, and therefore that gives a much higher score. We know that people who've required oral corticosteroids have got a much higher risk, and people with malignancy have got a much higher risk. And as a result, we're now in a position where we can now give this risk stratification tool and try and ensure those at the highest risk have the minimum contact with COVID in order to find ways of protecting our doctors and nurses and the healthcare professionals across the board from the risk of this virus, in order that we can safely tackle this disease to the best of our abilities, whilst minimizing the risk to those who are working with it. And on that note, I want to thank you for your attention, and thank you for being a wonderful audience and the opportunity to participate in such an important meeting. Thank you very much.
Thank you very much, Dr. Strain, for sharing with us your experience in the UK. Again, very rich experience, and you've been able to compare the UK and Germany with regards to early action. Obviously, Germany took early action ahead of Britain, and therefore the outcomes in Germany has been more favorable. That's a lesson for all of us with regards to outbreaks. Of course, you also reminded us of the mechanism of COVID entry and the role of ACE, ACE2, and discussed the asymptomatic vector and how that is important. The recognition of that is important in lockdowns, because the asymptomatic vector, if left alone, will be transmitting the virus, and therefore lockdowns are useful. And of course, that played a role in Germany compared with UK. You discussed the clinical characteristics and presentation symptoms and disease progression of the critical patients. And then, of course, the treatment modalities that have been explored in the UK your participation in the recovery trial and the finding that dexamethasone is very useful among patients requiring oxygen and of no effects among mild or asymptomatic patients. Of course, that will inform the rational use of resources so that, in fact, I think from your presentation, you actually mentioned that the use of dexamethasone in mild or asymptomatic cases may actually worsen the outcome. So that's very, very useful information for us, because people may just take it that dexamethasone is useful and then start using it widely. You also presented other treatment modalities, and this has been a very, rich presentation. We thank you for your time. We thank you for your effort. Thank you, Dr. Strain.
You're welcome. Thank you for the opportunity.
Yes, now it's been a long day for all of us. We've been here for over 3 hours, 3 long hours of useful deliberations. I think now, with the permission of the President of CMA, I will throw the floor open for questions. President, do you already have questions that you have written, you have collated, and we just put them to the presenters?
Okay, moderator, thank you very much, Professor Aki Oshibogu. It's been a very long day. I think the rapporteurs have been collecting the questions from the chat box. So I will ask them to perhaps read some of the questions. But before then, we still have our special guest in the house, and I will want to give them the opportunity to make any comments or ask questions based on the presentations. I can see a very honorable Commonwealth Secretary General still in the house, the WHO still in the house, and of course our able Secretary General of the WMA. So I don't know if they have any questions arising from these presentations or comments before we throw the floor open to respond to the questions that have been asked by participants. Thank you. I hope you heard me, moderator.
Sorry, President.
Did you hear me?
No, I thought the rapporteurs were going to present the questions.
Yeah, I said before then, our special guests in the house, if they have 1 or 2 comments or questions, because sure. I know they've been with us for the whole day, so I want them to at least make some comments if they have any or questions.
Let us invite them.
Yeah. So at the WHO Director General, represented by Dr. Mike Ray, and I don't know if you have any question or comments arising from these presentations. Okay, while the DG is still cogitating, let me respectfully call on our lovely Commonwealth Secretary General, the very profound, the very exemplary, and the very sagacious Right Honorable Patricia Scotland QC.
I think I need to be unmuted. Am I unmuted?
Yes, ma'am.
We're hearing you.
We can hear you.
Thank you very much. I have to say that I found today quite extraordinary and really demonstrating the depth and value of our Commonwealth interconnectivity, because I think there is such a richness in the experience, the differing experiences between all of our countries, that we are now, I believe, at the end of this session, able to come up with some very clear indicators about what to do, but just as importantly, I believe, what not to do. And I would like to really commend the last presentation made by David Strain, which was so brutally honest and frank about the sort of indicators that we really need to be aware of and the false positives that can lead you astray and then put you back on track. And I think that was extraordinary, but if I may say so, I was really impressed with the innovation that has come from Asia and from Africa and the work that we have done together. So I really just wanted to say that I found this, from my own point of view, incredibly helpful, because as you know, I am engaging, and I have engaged in almost 2,000 different webinars and opportunities and engagements with the press and others. And I think being able to better understand, culling from your acuity of understanding what it is that we're presented with and how we need now to go forward is incredibly useful for me. So it was a fast track seminar for me. And I think if anyone wants to give, any of the professors want to give me a viva now, I will try to do my very best. Whether I'll pass it, I can't tell you, but I can certainly tell you I'm much better informed. So thank you very much indeed. It's been an extraordinary 3 hours, and I've learned a huge amount.
Thank you, Right Honourable Patricia Scotland QC. We are most impressed by your comments and your presence. I want to assure you that even without setting any questions for you, we already know that you have a very high percentage with us. So you don't need to worry about the questions, because we've already scored you very highly. You know, even from your pronouncement, it's clear that you even have a thorough understanding of these issues. So thank you very much, and we appreciate that the fact that you stayed on to the very end. So we love you, we appreciate you. We'll call on the Secretary General of the World Medical Association. I know he will always have something to say, because he's another very blunt, frank, and passionate physician, one that you love to associate with any day, anytime. Dr. Ottmar Kloiber, please.
Thank you very much, Osan. I think that was really a wonderful walkthrough in this afternoon. Great learning. And what we have to do now is to try to bring this puzzle together and make this for a learning for our health systems. So what do we have to do in order to be better prepared? How can we really take the learnings from this crisis and make it, or take the best profit out of it in order to be better prepared for what has to come in the future. And we all can be very sure there will be another outbreak, there will be another challenge. And I think what we have seen today is, and that makes me very optimistic, we have made the best out of this catastrophe in order to learn from this and in order to gain knowledge for our healthcare systems and for the care we provide to our patients. Thank you very much for having a chance to be with you at this webinar. I guess there will be others to follow with that. And congratulations to the Commonwealth Medical Association. Thank you very much.
Thank you very much, Dr. Ottmar Kloiber. When we see you around, we're always very, impressed, and we are inspired any day, anytime with your presence. So thank you very much. I want to assure you that we are working towards the next webinar, hopefully in the next 2-3 weeks. But we're going to advertise that as we did in this for this present session. So this is a series, and so this is a first, but we are more interested in practical solutions. So as we get off this first session, we hope to package all of this together, and like you said, have a working document to guide our future interventions. So, and in that, we'll also be calling on your expertise and a very huge resource and repository to see how we can package this further going forward. So thank you very much, Dr. Ottmar Kloiber. I don't know if the WHO is still around. Otherwise, the floor will be made open now for participants who may want to have questions asked. But I call on the rapporteur, Dr. Joy Mugambi, to please raise 1 or 2, 3, 4, 5 questions because of time. And then while others may be answered by the speakers and sent to the various email addresses of those who ask the questions. We're also very conscious of the time, especially for our dignitaries who have come who have made time out of their very busy schedule. I know, like the Commonwealth Secretary General said, she has thousands and thousands of engagements everywhere. So we also need to appreciate that. So Joy Mugambi, any questions? Dr. Joy Mugambi, any questions that you have been able to collate?
Thank you very much, President Osohan, and thank you, Your Excellency, Right Honorable Patricia Scotland. A number of questions have come along, one to Professor Allen, and the question is, a mention was made that COVID-19 is a systemic disease. Is it that oral cavity is involved? Please explain that. I'll put them down as 3 questions because Prof. Allen, 3 questions were fielded to you. Camilla Graham asked, does any of the antibody data include children, since more children are asymptomatic? And this can also go to Dr. David, who has spoken quite a lot about what they are doing in terms of their clients. Another question came from Adiwani. Professor Amien, how can herd immunity be measured objectively? She had that you said 10% in Canada could be assumption. So what on your end can really mean an objective finding in terms of herd immunity? Then I'll field 3 more questions. Could we take answers? Then now I bring in.
Just ask the question so that the speakers will note them down. And
okay.
Then we can now address them serially.
There is a question which has come basically for, quite repeated by a number of attendees. Why is there a high male preponderance? And this, I filled it to either of the speakers tonight. How many days after discharge can a recovered client donate plasma? This came from Ramota. Use of calcium channel blockers in hypertension. What's your view on that? Because yes, we had Professor Alien talk about use of calcium channel blockers, and this attendee asked what's the role of use of calcium channel blockers. So Dr. David has quite highly elaborated the impact of AC receptors. There is a question that has come along quite often in terms of, out of all the speakers, we've not heard much about the rural areas where we are mostly within the African context and the Asian context. What is happening in the rural areas? Quite a lot has been learned in the urban areas, but are there cases in rural areas, people being treated? And one more question came in terms of discharge. Once symptoms are free, you self-isolate after 14 days. So how do you monitor these people within the communities? This was presented from the Caribbean perspective. Basically, I think, Dr. Osohan, I have cleared most of the questions that have come in, unless, so we have a comment from David Johnson, who says, great presentation. Dominican is interested in knowing more about the JAM COVID app. So probably a link can be shared by the presenters and we get to know more about that COVID app. Thank you so much. We appreciate all those who have dropped in their comments on the site. Though there was one more question for Chaudhry. Projected demand of PPE was stated to be 2.01, but the units were not clear. 2.01 of what? Thank you.
Okay, thank you very much. So maybe you may want to ask each of the speakers now to respond to any of the questions that were directed to either him or her. So maybe you start from Professor Allen, who was the guest speaker. Professor Allen. Is Professor Allen around?
Yes, thank you.
Okay, thank you.
Well, let me I jotted down the questions. Number one, the question of herd immunity. How does one objectively measure herd immunity? This would require proper seroprevalence surveys measuring antibodies. The challenge, though, is that we don't yet fully understand what antibodies mean. They certainly, if they're not false positives, and there's always a concern about that, indicate that a person was infected, assuming it's a true positive. But the question is, how long will antibodies last? We're not really quite sure. It's also important to separate just measuring IgG antibodies and doing more refined evaluations to measure neutralizing antibodies. That in some situations, very young children mount different types of antibody responses compared with adults. And again, the elderly at the other end of the spectrum may also mount different responses. So I would say that this, the verdict is still not in on this, and this is a subject of research. And I think the third one that I heard related to the nature of COVID. Initially, we all assumed that COVID was a respiratory illness, but as I've indicated and as Dr. Strain has indicated, COVID is really a systemic illness affecting various organs differently. What is not so clear, though, and Dr. Strain alluded to this, is the relationship between ACE2 and disease burden and the ability to be infected. So, for example, what we don't know is if somebody has a underexpression of ACE, how does that relate to the ability of that person to get infected and how ill they become? In other words, we don't know the relationship between ACE expression and the viral inoculum, the dose of virus that you get. And maybe you just need to have a few receptors and a few viral particles, and then things take off. So that's an area of research as well. I think those are the main. If there are other questions that are directed at me, I'll be happy to answer them.
Thank you very much. I think we'll call on Professor Celia Christie Samuels. If you have any question directed to you, this is a time to respond.
Could I just ask a question?
Okay, thank you, ma'am. Yeah.
Because one of the questions that have been asked others is, why is this a disease which is affecting men? But if I looked at Professor Allen's presentation, I thought on his presentation, he indicated that this was affecting 55% of women. So the majority affected women. So I just wondered whether he would address that, because it seems to be slightly different from some of the others who are suggesting that men have a greater propensity. And I just wanted to allow you the opportunity to just explain your 55%, if I remember it correctly.
Thank you, Ma. Professor Allen.
Yeah, that's a great question, Your Excellency, and I don't think we know the answer to that. Yes, we have seen more involvement of women in a Canadian context, one can only speculate. Like, for example, is this in any way connected with the workforce? That the nature of what people are doing and who gets exposed in various communities? I suspect that's what we're looking at. Obviously, what we also need to look at and research, our group and others are doing this as well. We need to make sure that there aren't biological differences. And so when we see these signals, we just need to look more carefully to make sure that there aren't biological differences. But that's a really great question. My gut feeling, though, overall, is that we're looking at the nature of the exposures based on people's occupations, but that's just speculation.
Thank you very much.
Thank you, Prof.
Welcome.
Thank you, Prof. Your Excellency, I don't know if you are okay with that response.
No, I am. It's just that I didn't want everyone to be carried away to think that men were victims when the professor had already identified that, as always, women are actually more susceptible, even if it's in Canada. And Canada is a big country. And just to say to you that this is Canada Day, so I needed
that's right.
to speak
it
up
is Canada Day.
Canadian work that's been done and their empirical data, which of course is very important to all of us.
Thank you.
Thank you, Your Excellency. Thank you, Your Excellency. We'll call on Professor Celia Christie Samuels now. If you have questions directed to you, this is the time to address them. Professor Celia? Yeah, we're waiting for you.
Yes. Okay. Yes, I'm here now. Thank you for your questions. The first one has to do with the JAM COVID-19 app. This one is available for download from the Jamaica Information Service, the government website. And what it is that once you download it, you can use it for up to a month. It allows you to get the most important information on the statistics of COVID-19, not only in Jamaica, but throughout the world. And it allows citizens to self-report their health status, book an appointment for testing for SARS-CoV-2, or even report on whether or not they're feeling ill, and also to request emergency services. So for example, if they need an ambulance or the police to help them. For Jamaicans and travelers and people who want to come to the country who are overseas, they can also access this tab through the immigration websites, and they need to register there within 72 hours or so before they come to Jamaica, because once they come to Jamaica, they need to show that they need to clear this process as part of the application approval to complete their immigration and customs declaration online. And the public is being asked to use and share the app to keep themselves and their loved ones informed and coordinated with our national efforts. So what we're really trying to do is to open up Jamaica and to make services more accessible, but in a more responsible way. So that's the app. Regarding females in Jamaica, our epidemic was skewed towards females as well. But what happens is that there were 2 workplace clusters which had a majority of women or young ladies. And therefore, that's the reason why women were more involved in our epidemic. Regarding, I think there was a question on plasmapheresis. We are approaching this in Jamaica as well too, as an option for treatment in our severely affected patients. We would say that patients would need to be asymptomatic, would have to be a few weeks out from their SARS-CoV-2 positive infection. Whereas we would really like to know the height of the antibody, because we do not have quantitative antibody tests available, and because the tests that are out there are not as sensitive and specific as necessary or as they should. we're not paying too much attention on that. But what is most important, though, is that we are making sure that we adhere to our blood transfusion requirements as it relates to ruling out other possible underlying infections and making sure that the transfusion requirements are met. I think those are my 2 questions, and that's my 3rd comment. I don't know if there was anything else. Thank you.
Thank you very much, Professor Celia Christie Samuels. I must say we enjoyed your presentation, and I'm sure Right Honorable Patricia Scotland is very impressed with your presentation as well. So thank you very much for making us proud. Anyone with Dr. Bowale, do you have any question directed to you? You want to respond now? Dr. Abimbola Bowale, is there any question that was addressed to you? Okay, while you are cogitating, Dr. Menelas Nkeshimana, you want to respond to any of the questions? I think some were directed at you.
Thank you very much. Many very, very interesting questions were raised, and I want to pick on one that was asked about the rural area. We might be focused in urban cities, but what's happening in the rural area? So by responding, I want to reassure the person who asked, when you impose these measures that limited the movements from overseas to inland countries, and you lock down the certain cities that are having high numbers of cases, you're actually preventing that the disease gets into your community. Because if it goes in the community, considering the living condition in our villages, the situation would quickly become uncontrollable and very volatile. There was a person who asked earlier that what do we have as a long plan as we test people when they leave the facility, and they want to test them once they leave the facility, 2 consecutive negative tests before discharge. Is it sustainable? When we do it right now, is that at the same time we are preventing to create a much bigger problem when they leave with the virus and they go back to their home village. It would cost more. So there is no harm to be very careful and discharge people when you are very sure and you do that when your numbers are still quite manageable. But I am sure countries that are seeing thousands and thousands of cases, probably they are struggling with the access to tests and other logistical nightmares. And there is always a way to compute that in the planning and do the right thing at the right time, and not to give up too quickly, if I might say. So in the next webinars, maybe we shall see if we can condense, we can zoom in our villages in Africa. We know how they live, 5 people in the same house, and they are very mobile because they want to trade here and there. What are we seeing in our African community? Maybe that's something that we should look into deeply for future webinars. Thank you very much.
Thank you, Dr. Menelas, for your response. I must say that Rwanda is one country that is actually doing very well on the African front. Just now, Rwanda has recorded just 2 deaths out of about 1,025 confirmed cases. And that to me is very amazing. I mean, it's very astounding, you know, and I honestly felt so sad when I was told that they recorded that 2nd death, because I was hoping that they could remain either at 0 or 1, because this honestly bothers us as custodians of the people's healthcare. This may be figures, but they are very, very significant, because every 1 additional death means a lot to all of us. Mm-hmm. So Rwanda has been doing amazingly well, and I want to appreciate you and appreciate all what you are doing in Rwanda. We'll call on Professor Dhruva Chaudhuri If you have any questions that were addressed to you, please, this is the time to respond now. Professor of Critical Care Medicine and a profound fellow of the Commonwealth Scholarship Fellows Committee. Thank you.
Thank you, Professor Osa. You see, there were two questions pointedly. One was about the plasma donation, when it can be done. First thing is that what we are practicing is that anybody who has 2 RT-PCR negative and has been discharged, on 28th day after that, person can give up to 400 ml of plasma. That is one. And if we want to take between 14 to 28 days, then it is absolutely essential for a person to be RT-PCR negative, because now, because of home isolation policy and change in the policy, people are being discharged or being released from isolation without RT-PCR. Therefore, for those patients where we have not done RT-PCRs, there we have made it mandatory to have 28 days of recovery. Whereas they have to be between 14 to 18 days, then they must have 2 RT-PCR negative. That is the first criteria for donation. Second is that we are not taking any multiparous women for it. The only persons whom we are taking for blood donation are either the men or the ladies who have never been, fertility is not there. So there are 2 particular groups which are there because of the issues which are there. A. B, that you can give plasma up to 400 ml after 10 days if need be, but by and large, because of the policy in our place, we usually don't take before 4 weeks. That is the second thing. And this 400 ml of plasma gets divided into 2 packs of 200 ml each. The challenge which we were facing in India was that we did not have the classical neutralizing antibody testing assays. Now they have become available now. So as a part of ICMR protocol, that is what Indian Council of Medical Research, this is how we did it. And data probably will be with you in next fortnight, how it has done it. But what we are doing as of now is we are taking only in patients who are moderately hypoxic. We are not giving into severe hypoxemia. That is how we are working on it. And the government of India, the state governments are going with the plasma banks now. So that this is something which has been turning out to be relatively more cost effective for us. So this is one part of it, which is going as of now. There was another question on PPE. I couldn't understand what exactly question was, but personal protection equipment, when we are looking at it in an Indian context, we had practically not more than 50,000 production in the month of January. Today in June, we are producing up to 5 million now. So you see, we have jacked up at all the places. So everything which was there in the garment industry, this has happened across Asia now. So you will be surprised the quality, the way it has come up. Initially, we were at loss. Practically, you ask me, I was involved in the procurement and standardization in my state and also at certain other levels. And we have gone to it. You look at the quality, the way it has improved over the last 2.5 months. Because of the certifications, the government has come up very stringently with the regulations of quality. And when we are talking not only, now we have started getting a medical textiles, which earlier used to be more of a polypacks, if I say so. So we are getting a medical synthetics, which are there. We are getting excellent gloves. Nitrile, obviously, Malaysia is one of the very big things in Asia, which is doing it. And similarly, we have got excellent goggles and face shields, and all quality one which we are working. And you will be surprised, the incidence of healthcare workers, depending upon how strong infection control plus the quality you are providing, is minimal. Wherever we have found out that our root cause analysis in our institution, it was more of a breach than actually because of that, what has happened. So I think if one message I would like to convey to is, please follow infection control practices to the hilt, and you are at more of risk of getting it, not from the COVID wards, but from the non-COVID areas. I think that is very, very important, which people tend to forget. As far as there was another question which I saw in terms of management of these patients once they are taken on the ventilators. What we are seeing is, like China, at other places, some of the patients have a very severe myocarditis. I think it is extremely important, the timing of the treatment. And this question, I'm certain Professor Strain will answer it. What we are practicing now in our institution and in India, and what we are recommending from the Critical Care Society, is catch them early, pick them early, hit them hard, and hit it so hard that it is taken care of. The duration of starting anti-inflammatory is around 6th to 8th day. And we are looking at 4 important vital signs. One is your pulse rate. Second, we are looking at temperature. Third, we are looking at respiratory rate. And fourth, we are looking at SpO2, that is the pulse oxygen saturation. And we are trying to pick up post bathroom if when one taken in a bath and has come out, or 6-minute walk test. That has become now a routine for us to tell people in the home isolation. And if anybody has a drop of 3% and all, we're picking it up. And depending upon the availability, because there was initially a lot of panic. So the doctors were in worry. And the nurses have done exceedingly well. Now, resident young doctors have done very well. So we are putting and getting a CT done. The moment we find out the lesions are there, along with this, the first choice anti-inflammatory for us is a steroid. And we had earlier using methylprednisolone, but dexamethasone is available across cheap. And we are using the dose here, not 6 milligram. We are using 0.2 to 0.4 mg per kg, and equivalent amount of steroids, which is our trial is going on now, hydrocortisone versus dexamethasone versus methylprednisolone in the country, multicentric. And then we have not used remdesivir. Remdesivir has just become available now. And our now target is to use remdesivir at 5th to 7th day. Because the moment you start using when the inflammatory thing is there, then it is a challenge. Third thing, we are trying a trial. Obviously, there is a negative retrospective trial for tocilizumab. We are using now tocilizumab off-rate. We are a part of a trial in a moderate one. So our target totally has become how we can prevent from A to B, that is from mild to severe disease, moderate disease, and can we prevent from moderate to severe disease. The basic challenge I told you in India, we are coming to social stigmatization and scare of the people because of the isolation, which was very stringently implemented. People thought they are putting into the jails. So we are trying to change that attitude. From nihilism, we are trying to tell them a hope. Myself being a COVID, I have been, but I was fortunate enough to have to mile this thing. I was away from the duties for 15 days. I came back, joined it, and trying to tell everybody that everybody can be fine. So we have to tell that message. 80 to 90% will have nothing. So we have to emphasize on it. And finally, my request to everybody, that is what I did with my friend Mahesh Nirmalan from University of Manchester. We are trying to tell them we don't need ventilators. We need good oxygen cylinders, availability of oxygen. That is the key. Somewhere wrong impression has gone that ventilators are going to save them. Please let us see that they do not go to ventilator. That should be the target rather than the other way around. And finally, what Dr. Strange said, diabetes management has become an art in these cases. And practically, right now, I have 25 patients with me in ICU. Out of them, 22 are diabetics and they are on insulin. So we are doing a very tight control, roughly around 150 plus minus 20. That's what we are doing. And multidisciplinary round should be the key rather than individual specialty. So that will bring their own values, and our mortality has suddenly dropped from, let's say, we lost 25 cases in 3 weeks period. And for the last 2 weeks, we have just lost 4 cases. I think that is the drastic difference when the different specialties brought it together. It's a systemic disease, treat it as a systemic disease, bring specialties together, and that is going to make a difference.
Thank you, Professor Dhruva Chaudhary. Indeed, we are very grateful to you. We know what you went through recently, but despite that, you were very committed towards participating in this webinar. So that shows great courage, that shows great passion, that shows great commitment. I will continue to pray for excellent recovery. You've recovered indeed, but again, yeah, thank you very much. So we want to call on Dr. David Strain now. If you had any questions addressed to you, please, this is the time to respond. Dr. David Strain. Dr. David Strain.
Hello, there we are. Sorry, I was just muted for a second. Talking against the mute, which is characteristic of the Zoom. So thank you very much. And there's lots of really good points that have been raised there. We've been doing a lot of work in children because with BMA, we've been involved in getting our children back to school. So that's obviously been very important. One of the things we've identified is that children don't appear to get a severe disease, but they do still act as carriers. If you do an analysis based on the serum of children, they will still have virus and they can still spread it, both via orals or also in the diarrhea, particularly in the younger children. So that's a very important message. So the children basically are acting as their own personal form of bioterrorism spreading this disease around nicely without getting sick themselves. So we've got that. So we've got a few comments on the PCR and antibody testing. So I personally, myself, was PCR positive. I was very fortunate. I only got a mild disease, but I was PCR. When we've now gone on to do the antibody testing, I do not have antibodies. So not everybody who has the disease develops the IgG against it. And the other rather concerning issue is there's still no clarity whether the antibodies do give you immunity. We've got 2 cases of anamnesic responses. That is, once you've had the disease once, it comes back second time and is much worse, remembering that the disease itself is killing the majority of youngsters due to its immune response to it. So like dengue fever, like Ebola, where people got the disease and each recurrent infection gets worse, we still are not sure that that's not going to be what happens with coronavirus. We are all hoping that it's going to be protective, but we haven't got there yet. And there's a question about the gender distribution, the male, females. So we've done a study looking at the ACE2 enzyme, and the ACE2 enzyme is approximately twice as high in men as it is in women. And we believe that's what accounts for this difference in exposure. That's why men in the bigger populations where we've had X many, well, 43,000 deaths, we believe that this increase in ACE2 is what's driving the men getting it. But we do see when we look at the healthcare population that there is this dissociation the other way, that women do tend to get it far more than men. And as we were alluded to, I think that's more about exposure. We have far more women in healthcare roles. We have far more women, particularly in the domestic healthcare roles and caring for people. And I do think that that's an exposure issue within the healthcare. Now, that may be part of the thing that was in Rwanda, where the deaths are so small, it wouldn't surprise me that this is something to come from the exposure within the healthcare system. I got a question on the chat about when to give dexamethasone, because in early disease, it seems to be harmful. In later disease, it's beneficial. What we do is, as soon as a person needs more than 2 liters per minute of oxygen, more than is usual, remembering that we've got people who are on long-term oxygen with COPD and heart failure, as soon as they need more than 2 liters of oxygen, more than usual, that's the point that we started. We're starting at 6 milligrams because that's the dose that we tested. I do fully agree with Professor Chowdhury that this is a fixed dose that has been plucked out of the air for no real scientific justification. But that's the dose that we tested. That's the dose that had the evidence. And therefore, that's what we're doing at the moment. But I would welcome any more evidence that can further refine that, because I really, I think Professor Chowdhury's approach at a dose per unit of weight is probably far more appropriate. And as we know more, we'll come on to that. I think the final question that was aimed at me was a question looking at pregnancy. And I was very careful not to mention pregnancy when we went through our risk stratification, because basically we just don't know. This disease is not old. It's not only 6 months old. We have absolutely no idea what an impact of a 9-month pregnancy with a disease that's only been around for 6 months. We have seen an increase, a tragic increase in the number of spontaneous miscarriages. We cannot say whether that's due to COVID specifically, or that's due to all the increased stresses that are going on around COVID with there. But what I can say is we are isolating all of our healthcare workers who are reporting pregnancy, because we just don't feel that's a risk that's worth taking. So all of our healthcare workers who are pregnant are being isolated from patients who have the disease, although they are still contributing in other ways through their healthcare endeavor. And I think that was pretty much the end of the questions that I had were aimed at me. I do, again, thank you for the opportunity to talk here. Thank you very much.
Thank you, Dr. David Strain. I don't need to talk further on the presentation you made. The Right Honourable Patricia Scotland QC has already lauded your presentation, and I must say additionally that Dr. David Strain really is a very profound researcher and scholar in the United Kingdom. Indeed, is on record that he performed the only study to date demonstrating the feasibility of individualizing targets for older adults with diabetes across the whole of Europe. In fact, this study informed the new UK guidance document for the management of older adults with diabetes and frailty, of which he was a lead author. And is also on record that his multidisciplinary approach to COVID management has resulted in one of the lowest mortality rates per admission, despite having one of the oldest populations in the country. So he's doing an amazing work, and we really appreciate you, and hope that you continue to get greater strength, greater wisdom, and greater resources to do what you are doing for humanity. Thank you very much. We'll be running up now. I don't know if the moderator is still there. Moderator, you have 1 or 2 minutes to recap so that we can round up. And
fortunately, President, I was recapping as you were making their presentation, and I guess it's been a long day for all of us.
Yeah.
The only thing I want to do is to thank all the presenters for being such wonderful people, quite experienced and quite eloquent in their presentation. And of course, I must thank Her Excellency, the Secretary General of the Commonwealth, for sparing all the time and being with us throughout the day till the end of the program. Thank you very much, Your Excellency.
Yeah, thank you very much, Professor Akin Oshibogo, a very able moderator for today. I must say it's been a long day, like you stated, and I cannot but also, on behalf of the Commonwealth Medical Association, express our profound gratitude to everybody who has joined us today. In particular, the Commonwealth Secretary General, the Right Honourable Patricia Scotland QC, who not only attended, but stayed till the very, very end. Also, we appreciate the Director General of the World Health Organization, Dr. Tedros Adhanom Ghebreyesus, who, of course, attended this session in spirit, even though in body, he sent Dr. Mike Ryan to represent him. We appreciate their presence today. Also, we appreciate our own Secretary General of the World Medical Association, Dr. Ottmar Kloiber, for staying to the very end. I know Ottmar is someone who can stay for the whole day when you have a quality engagement, and I think he has found this to be one of such. So I want to appreciate him on behalf of the Commonwealth Medical Association for gracing this occasion, and of course, staying to the very end. Of course, the chairperson of the Commonwealth Health Professions and Partners Alliance, Professor Tony Nelson, I'm happy that you were able to make it here. All the ESCO members, executive committee members of the Commonwealth Medical Association, I want to thank them for all the energies and support and initiatives. Of course, the moderator, we cannot thank you enough. You are always very profound. I'm sure that even our guests, our special guests, have been very, very impressed with your analysis and summaries of the issues, even though there's still a lot more work to be done going forward in terms of repackaging this whole thing into a document that will need to present formally to the Right Honourable Patricia Scotland QC and other relevant leaders in the Commonwealth and, of course, the global community. I also want to appreciate all our speakers. Indeed, someone tweeted a while ago that he has never seen this, potpourri of very, profound speakers, and was wondering where the CMA got them from. And I said, well, when they reach us, we shall try to reveal the secret to them. But I must say that they've been very, very, valuable, very, very profound, very, very inspirational. And indeed, especially for those who were still recovering, in fact, yes, I've recovered, but in terms of, what it takes when you have been declared negative or you declared free, but you still need to recover psychologically and otherwise. For them to still be able to make this presentation, I think we cannot but continue to appreciate them. We want to thank all our speakers for doing justice to the presentations. You did not disappoint all of us. You did not disappoint any one of us. In fact, you exceeded our expectations, and we hope that we'll continue to have the best from you Surely this is not the last of it, because the CMA has an agenda for all the speakers. And even though we have not revealed that secret, that mission to them, but I need to let them know now that their mission has not ended. And I'm sure the Right Honorable Patricia Scotland will be ready to, of course, also engage them. So we're going to be making use of their services going forward, because what they have done today has been most profound. We want to thank them, therefore, for gracing this occasion. We also want to thank all the leaders of the professional bodies and national medical associations across the Commonwealth, and indeed for making this, making their presence felt during this presentation. We want to thank all our participants, and we want to assure those who have been asking whether there are CMA credits that we shall do the best we can to attend to that request. But in any case, we want to assure you that in future events, perhaps all the suggestions that have been made today will be keyed into our future engagements. We hope to have another session in the next 2-3 weeks. And so I think that will come out even better than today. That is not to say that today has not been good. But again, like they always say, the only thing that is constant in life is change and progress. So we want to change, we want to move progressively ahead, and we want to assure you that the next sessions in the series will be even better than what you saw today. But we want to thank all our rapporteurs who have been very supportive today, Dr. Joy Mugambi, Dr. PDJ Danjumbo, and of course, Roland Aibovo. They've been very wonderful collating all the information and also tweeting from time to time, and of course, Facebooking, if you may allow me to use that word, you know, and if you go on the Facebook now, you're going to see a lot of information there. Twitter handles, they've been very busy doing all of that, doing the background work. Our IT expert, who indeed is a prospective medical doctor. And because again, in the CMA, we try to encourage even the younger ones in our fold. And so this setup you are seeing now was made very possible in terms of the expertise and the commitment and the technology by Isaac Ocheku, who is a budding medical doctor. I want to appreciate him because he's been in the background. We've not heard him speak, but I'm sure when you see him, you'll be very impressed with the quality of job that he has done. So I want to appreciate him, and appreciate also the Nigerian Association of Resident Doctors for their level of support for this engagement. We want to assure you that all the lapses that you may have noticed in this session, we will certainly make efforts to correct them going forward. But I think it's been very encouraging thus far. All the questions that could not be answered, even by those who perhaps had wanted to have opportunity to speak before this audience, I want to assure you that because of time, we could not accommodate that, but we'll try as much as possible to respond to those questions and send them back to those who asked through their various email addresses. We shall also try to put excerpts of these presentations, of course, with due permission from the speakers, on the CMA website. So please watch out on the CMA website for excerpts of this session. Of course, we shall appropriately document them. We also want to assure you that going forward, we shall package the outcome of this session into a document that will guide clinical case management going forward. Of course, we shall approach the Right Honorable Patricia Scotland QC for further contributions and, of course, endorsement of that strategic plan. We also want to thank again all of you for making this possible, because without you, we would not have had this amazing session. Like I reported in my opening speech, we had over 1,200 people that registered for this. And of course, they came from 48 countries across the world. So we hope that going forward, we should be able to move to cover the whole of the Commonwealth. In fact, that is almost the whole of the Commonwealth, because Commonwealth is 54 countries. But I think we shall make effort to cover as much as we can next time. So, but I want to once again appreciate dignitaries, the Right Honorable Patricia Scotland QC for staying to the end. I also want to appreciate again the Director General of the World Health Organization, Dr. Tedros Adhanom Ghebreyesus, and the Secretary General of the World Medical Association, Dr. Ottmar Kloiber. Thank you very much for coming, and we wish you a very happy evening, and of course, a very happy new month of July, because this is actually the first day of July, and with this successful outcome, you can be rest assured that every other thing we do going forward will be very successful, if not more successful than what we have had today. Thank you very much for coming. May God bless all of us. To God be the glory. Thank you.
Thank you, President.
Thank you very much.
Thank you.
Isaac, you want to share, so that everybody can interact, and as we proceed to our various homes, I'm sure the Right Honorable Patricia Scotland want to see as many of the people here present, and also people who have the opportunity to wave at her. I'm sure Dr. Otmar Klober want to wave at everybody. So Isaac, please make that possible so that we can go home happy with ourselves. Thank you very much. Yeah, you can wave at the Commonwealth Secretary General now.
I hope it's just not 4 or 5 of us left.
Yeah, thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.